welcome. It's nice to see in the chat box those of you that are from all different places, all around the world. Yay, even Egypt, welcome. So please, if you're new to Zoom and you're not familiar with it, you can open chat, and that way you can ask questions and sort of see what other people are asking too. That's always my favorite part. We're still letting people in. It's a big group, so we're gonna keep doing that. Now, today is a very content-dense class. If you've taken some of my classes before, I often will cover 5 or 10 different topics in 2 hours, and this class is entirely dedicated to SIBO. We have a lot of practitioners on here. We have a lot of patients on here. Some people are wondering, what in the world is this SIBO thing? And some are just all too familiar with it because they've been dealing with it maybe for years. And it's a really good topic that we can dive deep into, and a lot of layers. Some people, they're just, it's not that it's the most complicated thing, it's just, it's involved, and it has to be customized and really tailored to that patient. So everyone really needs their unique care. So I hope by the end of this class, you feel very well informed and empowered, whether you are the practitioner or you're the patient wanting to restore your own health and have better conversations with your practitioners. I know a lot of people on here are our patients, but some are working with all different practitioners around the world. So excited to be able to share information with you. And SIBO is a topic that we've been getting new research on. And so there's a lot of cutting edge information I'm going to share with you. So I'm really excited for that today. All right, so I know everyone's still jumping in, but I want to start moving forward. This class was called Bloated. Not everyone with SIBO is bloated, but it is certainly one of the most common symptoms. And what you'll often hear from patients is, oh, by the end of the day, I feel like I look pregnant. It's just too common. It's not a weight issue, but they wake up in the morning and they feel whatever size their body is. And then as they begin eating, they get bloated. And by the end of the day, they say their jeans don't fit anymore. You know, they're really uncomfortable. So there's certainly a high percentage of people dealing with bloating. And then we'll talk a little bit about some different bloating patterns, because we're going to be talking mostly about bacteria today. But some people also have yeast, and that can contribute to bloating, but a little bit different. So we'll get into that too. Okay, so as we move ahead, hopefully you all can see the screen. If there's any issues with that, let me know. It should be recording too. So if anyone, Katie, if you see it's not recording, let me know. And then let's see, what else did I want to tell you? No, I guess that's it. As long as you can see the screen, we're good to go. This is the disclaimer. This is an educational class, so it doesn't mean we have a patient-doctor relationship. I'm going to share a lot of information with you. I'm even going to give specifics with protocols, but that's not like just a generic, hey, everyone should do this, right? So always when you hear information, do your own research, work with your practitioners. And we're doing our best to record this so we can send it out, because it is a lot of information and we want you to have the recording. So that should come out next week. Okay, here's the exact list of topics for today. So as you can see, it's quite a bit. Really all about SIBO. What is it? What contributes to it? Even the types, how we're changing the labeling, you know, the role of IBS, what we've learned that's new about IBS. I'm going to share with you some flow charts for protocol and care that have been in use for the last couple of years, and I made a new one for you, never seen before. So especially those of you who are practitioners, I hope I'm going to give you some good tools. We'll talk about some new testing options. Some testing's been around for years. Some testing has been used in research, but just became commercially available to practitioners in the last few months even. We'll talk about food. Always that's a huge question for patients. Like, what do I eat? because so much of this uncomfortable bloating is triggered by meals, and it can be confusing. Well, part of why it's confusing is 3 different gases can be involved in SIBO, and quite frankly, the meal plan is different for each of them. Also, the meal plan does not heal it. The meal plan is to help resolve symptoms and make your life not as miserable, but you really don't resolve SIBO with a diet. So we'll get into that. We're going to talk about stuff like migrating motor complex and prokinetics. So if that's a weird phrase to you, it won't be by the end. And then we're going to really dial into the specific protocols to use to resolve it, talk about how not to relapse. It's a very high relapse condition, often up to 85%. So that's why, you know, people can suffer with it over and over again. So we're going to talk about root causes, what needs to be resolved in order to not get this again. And then sometimes as much as 1/3 of the patients aren't going to be able to resolve it because they might have a root cause that can't be resolved. So then how do we live with it and still have the best quality of life? And then we will talk about things that get in the way, like why is someone not getting better? And then we'll do live Q&A. So that's the plan. Does that sound good? Thumbs up? All right, wonderful. Let's start. I know we're still adding people in. As we're adding, if you don't know, this is our functional medicine group, and Katie can paste the link in there so you can join it. We answer a lot of questions and, you know, more than just SIBO, but it's a great group of people, lots of topics, lots of sharing. We have a good sense of humor also. But next week, if you're not familiar with Siobhan, she leads one of the biggest SIBO support groups on Facebook, and it does such a great job of bringing experts to the public. And this is something she has dealt with herself. I'm interviewing her in our Facebook group next week. So I highly recommend get in there and see it. We're going to be able to do a live Q&A. Her book just came out, Healing SIBO. And, you know, she's interviewed me. You're going to see that in a couple weeks, actually. I did a presentation with her on lymphatic drainage. And she's interviewed Dr. Mark Pimentel many times. I'm going to mention him. She does a lot of work with Dr. Seebecker, who's really dedicated to SIBO for many, many years now. So, and much more. So she's wonderful at bringing information to the public and incredible support. So that's going to be a fun interview. These are just a few. If you're new to our classes, here's a few reviews about the classes. Katie will post our Google review link. It always feels silly to ask, but for small businesses, it's incredibly helpful when you leave Google reviews, especially if you write out a sentence or two. So even if you're not a patient, but you like the class, certainly you can wait and make sure you get value from it. But if you like it and you want to put in a Google review, it is very helpful and supportive. So thank you to all those who have. We just finished a class series, so you can go and watch them. The recordings are on there. You don't need to opt in. They're available. So I'll just let you know. There's a lot more on there, but here's what we did recently. The first one was all about weight loss. The second one was all about nutrition, blood sugar balancing. We did cover more on weight loss also and really customizing it. Part of why I mentioned this is because blood sugar balancing, we're going to talk about that with SIBO. So sometimes having access to a class that dives in deeper can be helpful. We did a class on thyroid health and adrenal health. Absolutely plays a role with SIBO. We're going to talk about that towards the end of this class today, but a lot of people dealing with hypothyroidism, that can set you up and be more likely to get SIBO because that can slow digestion. So anything that contributes to slow motility through the GI tract can play a role with SIBO. And you know, adrenal issues like a hypercortisol, hyperstress state that will also impact digestion. So That might be a helpful class to view. Just pretend it's Netflix, right? Watch it at night. And then we did a class on hormones, sex drive, gut health, and digestion. This is a much more detailed class, but we did cover a lot of digestive disorders in that class and more about sex hormones. And then the last class was heart health, depression, anxiety, PTSD. So those are all, Katie, if you can put the link, those are all on our website. You just go to the video tab. And as I said, no need to opt in. Watch it at any time, and I hope you get benefit. You'll also see we do have a 15-minute consult with our health coaches. For those who want to learn more about the office, we can share that link with you. That's a lovely service that's provided. I think whoever your practitioners are, it's very helpful to interview them and make sure it's going to be a good fit for you. Okay, let me tell you very briefly about myself, and then we're going to dive right into content. So a lot of you know me already. I'm Dr. Zachary. If you don't know me, then welcome. I'm so happy to have you here. It is definitely my passion to teach. I really love to inform people. Our doctors are so wonderful and they work so hard to help us, but ultimately as patients, we're in charge of our body, right? We're living in it. We have to have the motivation to make the changes. We sometimes have to seek out multiple practitioners. So we're really driving the bus. And when it comes to informing the public, that's my motivation, is making sure you have those tools. I also love coaching practitioners. It's a huge passion of mine. For those who don't know, before I had Body Love Cafe, I had a completely different business where I coached actually 20,000 different entrepreneurs, and the vast majority were in health and wellness, about how to build a business, how to create a lifestyle that was sustainable, how to communicate with your patients, how to market, what EMR to use, all of those things. So that's a passion. But the reason I created Body Love Cafe and how I became really one of the worldwide experts in SIBO was very much personal. Was I had it myself. And, there's multiple reasons. For me, I have a primary immunodeficiency. So that was really one of the issues behind it. And I got very, very sick in my last career, not because of that, but it was a life-changing thing. I had to leave everything behind. I was a single mama, and I had to move home with my mom, which is always rough to do as an adult. Financially lost everything, had to start over, close the business. Social Security declared me permanently disabled, said I'd never work again. I had 7 specialists. I was on 8 prescriptions. I spent 22 hours a day in bed. And I went to John Muir, the local hospital, the infusion center with the cancer patients, and I had IVIG every 3 weeks. The treatment was a little over $700,000 a year. Insurance covered most of it. I had to pay 20 grand a year just for that portion. And I never felt better. It was just miserable. It was not a life. And so that's how I got into functional medicine, was having to learn for myself. I went back to school. I've gone completely through the IFM program. I'm one of their certified practitioners, one of only 1,500 doctors worldwide. It's a very rigorous program. I've done thousands of patient visits and labs and taught. And probably the biggest testimony is, even though, we're all still on our healing journey, is I was one of the rare people to step away from disability, enter the workforce again, start a clinic that became very, very successful. It was just me with 100 square feet. And within the first year, we had to move twice, go to 22 walls, 1,400 square feet, multiple practitioners. We just won Best of the Bay in 2020, even though 2020 was a rough year, wasn't it? I can tell you, first and foremost, I worked with practitioners. I always believe putting your money where your mouth is. I paid all these practitioners. I saw them as a patient. I saw local docs. Everyone was helpful in some way. And then I just started seeing experts all around the world even in Australia. And then, you know, as I learned, I ended up becoming the expert too, and getting really complicated cases, people who would even fly into our clinic. Now we're able to see everyone virtually and do telehealth. So that's really opened borders. And we work with patients and clients on multiple continents. I coach doctors on 4 different continents. So things have really evolved, but SIBO is definitely a passion of mine. So that's sort of the basis of my story. I'm happy to answer more questions if you want, but that's the short version. Okay, so let's keep going. One is I want to give a nod to the, you know, big SIBO pioneers. Dr. Mark Pimentel is remarkable and does most of the research out of Cedars-Sinai in Southern California. What he has brought to SIBO education over the decades is phenomenal. A lot of the cutting edge science I'm going to present to you today comes directly from his work. So, you know, phenomenal work that he does. Dr. Seebecker runs an informative SIBO site, and really one of the first ones to get out there and bring it to the public and really make this something that was known. So if you don't know about her, it's fun to read her story. And she's still completely active. She's not seeing patients, but she's teaching and presenting and, you know, co-leading and hosting. We have a SIBO Con, you know, like Comic Con, we have a SIBO Con. And she works with Siobhan a lot. So Dr. Seebecker is definitely a huge pioneer in the field of SIBO. Okay, let's talk a little bit about digestion, a quick tour. And this is really for, you know, some of the newbies here. I go through this in more detail, by the way, in class number 2. So the chemistry of food, if Katie can share that link, because I'm going to do sort of a short version here. But the bottom line is, as you see this image, see the part that looks like spaghetti in the middle, the small intestines? SIBO is a bacterial overgrowth. We're going to talk more about it, but it's not just talking about what is overgrown, it's talking about a location. And the small intestines is not sterile, but really bacteria should not be hanging out in there that much. And so this is an overgrowth in the small intestines. And why do we care? The small intestines is about 15 to 22 feet long, depending on the individual. And this is where you absorb your nutrients, which is vital for life and health. So you don't want a bacteria in there eating your nutrients, robbing you of nutrients, being a competitive force, releasing gas, causing that bloating that's so uncomfortable, leading to, you know, leaky gut, and immune response. There, you know, we'll really dive into all the secondary issues that come with SIBO. But it's really one long tract from, you know, mouth to anus. Even though it's one long tube, I describe it as like moving, you know, a kid moving through school. It's the same kid, preschool, you know, kindergarten, elementary, junior high, high school, college, and yet the environment's very different. From the mouth to the stomach, the small intestines, the colon, the environment's very different, but it's moving through the same tunnel. So as you can see here, we've got SIBO listed, naming that location, small intestines, but we are going to be talking about the colon also. I did list Candida. I see clinically up to about 2/3 of people will have a Candida, which is a yeast overgrowth. Yeast and mold are under the fungus category. Candida is, there's like 600 different yeasts, but it's Candida about 97% of the time. So that's why you hear those terms sort of used interchangeably. But a yeast and bacterial overgrowth, I see about 2/3 of the time. And quite frankly, SIBO's often easier to resolve and the yeast takes longer. Some people also have, you know, parasites. So unfortunately, we're not limited to just one condition. I highlighted acid reflux and heartburn because H. pylori overgrowth in the stomach and hypochlorhydria, low stomach acid, is a risk factor for getting SIBO. And sometimes for those of you that are practitioners, we're going to talk more about looking at tests and putting the pieces together and comparing different tests. Especially when you really want to resolve it, you need to have a multi-pronged approach. But the stomach is supposed to be like a battery, you know, a pH of 2 or less. It's supposed to be very acidic. And people who deal with acid reflux think, oh my gosh, there's too much acid, let me just take Tums. Well, someone could truly have an overproduction of acid, but often they don't produce enough acid. And what happens instead is, you know, the food basically sort of rots and it's just as gross as it sounds. And it produces like acids of putrefaction. Those will rise up. Your esophagus, your throat doesn't care where the acid comes from. It doesn't want acid in there. It's going to hurt. So anyway, short version is the stomach should be very acidic, besides the fact that it needs to chemically and mechanically break down your food. The fact that it's so acidic protects us from food and waterborne bacteria. And so when it's not acidic enough and you lose some of that protection, then you have a greater chance of that bacteria moving on into the small intestines. That's one of the risk factors for SIBO. And you'll see later, one of the ways to prevent relapse is to have a good, effective digestive aid. We're going to talk about constipation. Now, SIBO patients have constipation or diarrhea or both, alternating. But constipation is certainly a sign of slow motility. And if you don't resolve constipation, you will never resolve your SIBO and possibly a lot of other conditions. So we'll talk a bit about that. You know, anything that causes slow motility just allows for more overgrowth, right? Especially you're forming a stool, it's going to move too slow. It helps bacteria to overgrow, the wrong kind. All right, let's talk briefly about IBS. IBS is irritable bowel syndrome, and it used to be seen, and I think a lot of primary care physicians and even some GI docs still use it as like a catch-all. It's a diagnosis of exclusion. Someone comes in and they say, hey doc, I'm bloated, I feel miserable, I'm totally constipated, this is ruining my life, it's gotten to the point where, you know, I can't eat out, etc., etc. And they might order an endoscopy, they might order a colonoscopy. There's a lot of things they're working to rule out, so it can be a very expensive procedure and an invasive procedure to go down that route. And then when they order those tests, and quite often they don't see anything, and we use those tests, but we use other tests in functional medicine, which are very advanced. And I will talk a bit about those, because what you see when you look for more than just pathology can provide incredible answers. But anyway, so let's say the GI doc does some of these invasive testing, and you know, they're looking for inflammatory bowel disease and cancer and things like that. So when none of that comes up, but the patient's still miserable, they say, well, you have IBS. And sometimes they think, a lot of women get this, oh, it's just in your head, and if you weren't so stressed, it wouldn't be a problem, and here's anti-anxiety pill or an antidepressant, and they're sort of just, you know, written off. A couple things about that. Dr. Pimentel's trying to change the language for irritable bowel syndrome, because one of his arguments is it's not just really a syndrome anymore. Now we understand more about the physiological issues behind IBS. But currently there's about 40 to 60 million in the US and 1 billion worldwide diagnosed with IBS. There's a lot of, productivity and work that's lost to IBS. So that's all important to understand. So we want to make a dent on it, and there's multiple things that can cause IBS, but a fair amount of IBS, enough that we should be looking, is caused by food poisoning. And we've learned enough about food poisoning that we have two conditions that we sort of name for it: post-infectious IBS and post-infectious SIBO. We're going to talk about both today and really dive in deep to it. But Dr. Pimentel was behind the creation of the IBS SMART test, which really shows the mechanism of food poisoning. So about 1 in 9, which is what, 11%, about 1 in 9 that will get food poisoning will get this secondary, what's really an autoimmune condition. And you can do this simple blood test, and you're looking for vinculin and another marker, CBT. I can't remember what it is exactly without looking. I'll put both of them up here so you can see it. And when you see that, then you know food poisoning was behind it. And sometimes people don't even remember that they had food poisoning. Most of the times it's quite memorable, right? You had an acute episode of diarrhea. Maybe everyone who ate at the restaurant had it. But other times, people aren't as aware. But anyway, so a fair amount of IBS can come from food poisoning. We're understanding more about the physiological reasons behind it. And so many IBS cases also have SIBO, or SIBO is really the underlying cause of their IBS symptoms. What I've seen, there's research that shows a whole different range of numbers, but I would say about 50 to 85% I see is clinically accurate that are diagnosed with IBS and really have SIBO. So without getting a correct diagnosis and the proper testing, you don't know what to do to move forward. So we'll talk about that. Okay, so with that, what is SIBO? Because for many people, that is a new term. SIBO stands for small intestinal bacteria overgrowth, and we're going to keep breaking down the types. But basically this bacteria, of course, we want and we have plenty of bacteria in the large intestines, the colon, but bacteria is getting in the small intestines, and then that's where it sort of sets up home. And when you're eating carbohydrates, it's like they hit Vegas and they got the buffet, and so that's their preferred food choice. And then this bacteria, depending on what type, they produce a gas, and that's what contributes to your bloating. So basically, there's the small intestines, there's our little cartoon critters, and you're not supposed to be there. So what are some common signs and symptoms? Bloating first and foremost, IBS, constipation, diarrhea or alternating, gas. Some people get a lot of belching, weight gain or loss. And those who have weight gain from this, I've never seen any of our patients not lose weight with the proper protocol. So that's often good news for people. Abdominal pain, some cause more abdominal pain than the other, like hydrogen sulfide, the third type of SIBO, can really be the culprit behind more abdominal pain. Nausea, allergies, food sensitivity, acne, sorry, I'm still in my eye, acne and, eczema, a lot of these things, SIBO can be ultimately what is underneath it, fatty stool, things like that. All right, what are some of the common causes of getting SIBO? Anything that causes slow motility, so I put that in red there. Slow motility, again, is something moving too slow through that long GI tract. The least amount of time in the mouth and the esophagus. Next is the stomach, and then the small intestines. Spends the longest amount of time in the colon. Low stomach acid, certain medications, antibiotics, proton pump inhibitors for sure are a big culprit behind SIBO, even use in the past. And there's new research that's been published, and thank you to the MDs and PhDs doing it, called deprescribing PPIs. IFM has some good handouts on that for practitioners and for patients about how to get off PPIs. So always work with your doc. But it's just become such common knowledge now about how damaging it is to be on a PPI that they should be prescribed far less than they're currently used. Even some of these over-the-counters are problematic, immunosuppressants. Surgery, scar tissue can be an issue. Could be a tummy tuck, endometriosis. I was thinking of a patient that has endometriosis, you know, not just in the uterus, but it's infiltrated, gone through the bowel, even up into the lungs. But a C-section, what else? Exploratory surgery. Maybe someone had their gallbladder out or whatever. So, you know, anytime we cut into the body, or even not a cut, but like uterine ablation, okay, things like this. Anytime we cut into the body in this way, our body is going to repair and it's going to form a scar. And if it's just a nice, pretty scar, then lovely. But some people are prolific scar growers and they form keloids, and or like the endometriosis example. So sometimes it infiltrates the bowel. That can be very problematic. Sometimes it doesn't, but it's just even bumping up against it. It can cause what seems like a sharp turn in the bowel, right? So these are things that can interfere with motility. A risk factor for SIBO. Hypothyroid, low thyroid, again, will slow your digestion. So I already mentioned that. Stress, blood sugar imbalancing, infections. We've learned more about H. pylori, E. coli, Klebsiella. These overgrowths are very common with SIBO. So we're going to talk a bit more about that. Food poisoning, of course. There's some structural issues. You could have, you know, we talked about bacteria getting from the stomach to the small intestines. It can go the other way. We could have bacteria in the colon getting up into the small intestines. So the valve right there is the ileocecal valve, ICV. And so, you know, the tail end of the small intestines is the ileum, and then it moves into the colon. First the cecum, your appendix is right off there, and then ascending colon. And so if there's damage to that valve or it's stuck open, that's almost like an open door for bacteria to move. And then unfortunately methane, which we're going to talk more about methane, what we've learned about methane over the years is, first of all, those little suckers can feed themselves. Well, that's a bummer, but they're also quite modal, and they can actually move on their own into the small intestines with ease. So that's problematic. Traumatic brain injury, how does that play a role? Well, some people have had traumatic brain injuries. For example, they could have damage to their vagus nerve, cranial nerve 10, which plays a very important role in peristalsis and gut-brain communication. So anything that interferes with the neuronal communication to the gut, also leading to slow motility, can be a risk factor. Again, just sort of seeding at the end when it comes to avoiding a relapse. If these issues are there as a cause of SIBO and they're not addressed, SIBO will come back. All right, why do we want to care about it at all? Well, if you have SIBO, you already know, but for those who haven't dealt with it, it's not just bloating. Like some people say, oh, you know, this is a tiny, thin person. They get a little bloating. Who cares? You look fine. That's not it. And it's not size dependent. It's uncomfortable and sometimes extremely painful. The gas can almost be like a space occupying lesion. It's pressing up against your belly, but then it can also impact other organs, other function. Just think of, you know, anything. Think of even a pimple, right? Let's say you get a pimple on your forehead. There's not a lot of extra, you know, skin and tissue and fat there. You get a pimple, it really hurts. You're like, how does a tiny thing hurt so much? Well, it's a space occupying lesion taking up space. And so this gas can act in much the same way. And the patient can be incredibly uncomfortable to downright sharp pain. You could have malnutrition. You could have someone who's 300 pounds overweight and they're malnourished due to SIBO. They're not absorbing and assimilating their nutrients that they desperately need from food. And then it can lead to a multitude of secondary conditions. So let's talk a little bit about those. Inflammatory and immune conditions, right? Inflammation is a broad response in the body. Taking up space, inflammation will do that, but there's also noxious chemicals with inflammation, immune conditions, depression, anxiety, rosacea, atherosclerosis, chronic fatigue, nutritional deficiencies. It's quite a long list. And then the real life challenges I wanted to mention, just so for the practitioners who haven't experienced SIBO, wonderful, you don't want it, but just to have compassion for the patients, the patients can get very painful bloating right after a meal. Their clothes cannot fit after a meal or later in the day. So think about like going to a wedding and you're dressed fancy or something, and then you're nervous about even eating the meal. It can make them feel like they want to hide from taking pictures. They're scared to go out to eat with their family. Maybe they can't go to restaurants at all. It changes their relationship to activities, or gut health becomes this overriding thing that they can't go anywhere or do anything or plan their day without keeping their gut health in mind. It can strain relationships, having a partner who doesn't understand. It can strain that doctor-patient relationship, which you want to have a good relationship with your functional medicine practitioners, your primary care physician. If you have a GI doc in your life, an OB/GYN, you want to feel seen and heard. Oops, someone wrote on the screen. I'm trying to remember what I have to do. I think I have to stop sharing. Hang on one second. Let me stop sharing and then reshare it. That should get rid of it. Okay, so just be careful not to write on the screen or it'll stay the whole time. Oh, Barbara, it's you that it's happening, love. So whatever you're doing, if you could stop, I'll share again. Okay, what else? The doctor-patient relationship, again, you want a doctor who understands and doesn't think it's all in your head. There can be a loss of self-esteem, feeling like an outsider, especially if you're avoiding social events. Of course, most of us have been stuck at home for a while now, but you can imagine, with normal life, people going out and living, and then they're the only ones stuck at home. Hang on one second, because I stopped sharing. I have to open up participants again. Okay, great. All right, so I think we've got that. Let's move on. So a day in the life of a SIBO patient. Some are red lighters, right? They're working on a protocol. They don't see any change. You're going to have to get more creative. Some are yellow. They get a change. They feel better for a while, but they keep relapsing. So they keep having to do protocols over and over again, or they have some underlying condition that cannot be resolved. So in that case, we are going to have to manage it. There won't be resolution, but we want the best quality of life possible. And then green is ideal, right? Completely resolve it, full restoration of diet. They can eat fermentable foods and fibers. I was just talking to a patient this week that had SIBO. We had some protocols we did years ago. It's never come back. That's wonderful, right? But like I said, up to about a third of patients might not see resolution. All right, this tells you a little bit more about what's happening. I feel like I've covered this, so I'm going to keep moving forward. But you'll see the slide if you want to go over it in more detail. Let's talk about this, understanding the types of SIBO. So the classic understanding was hydrogen dominant, which was typically, those patients had diarrhea or maybe even asymptomatic, or methane dominant. So H2 is hydrogen, CH4 is methane. And the methane isn't even a true bacteria, it's archaea. We'll talk a bit more about that. So it's a different type of organism. And the methane is typically constipation dominant. So that's our classic understanding, and we'll talk about the testing. And then a latecomer, or for some of you a newcomer, but was hydrogen sulfide. So that's the third type of gas, and typically diarrhea, but you could also have a mixed state, diarrhea and constipation alternating. And some people have more than one gas present. So it's not always like you just have one. So that is definitely an issue. When you're testing, I'm going to show you some test examples. Sometimes you won't see the hydrogen because it takes 4 hydrogen to make methane. It takes 5 hydrogen to make hydrogen sulfide. So sometimes the hydrogen marker can appear lower when the other markers are high. Cause-oriented, some people describe SIBO and they focus on the cause-oriented, so they'll talk about post-infectious SIBO. And for practitioners, when you're getting like that intake for a patient, you see they're bloated and there's a history of, you know, food poisoning, this is something definitely to start thinking about. A big picture view of SIBO is, well, it's just a symptom of something else that's wrong. And that's not an inaccurate way to describe it, because again, the root causes, SIBO, even though it is discussed at its own condition, it really is a sign and symptom of something else going on, and you need to get to the bottom of it. And then the new kid on the block, this is what Dr. Pimentel's trying to change. One of the terms we use is IMO, intestinal methanogenic overgrowth, because methane is not a true bacteria. So SIBO might not be the best way to describe it. Also, patients can have a lot of problems with methane, and it's not in their small intestines, it's just in their large intestines. So that's why he's trying to encourage IMO, you know, just intestinal methanogenic overgrowth. That's a new term though. Most of your GI docs are not going to know it. Okay, so 3 distinct developments and gases as we're learning and moving forward. I already said quite a bit of it, but typically, like I said, we have some good research. 60% is a pretty well accepted number for 60% of IBS diarrhea patients, and IBS mixed cases, diarrhea and constipation, are going to truly have SIBO. And then especially what they're seeing in research is Klebsiella and E. coli. They're doing duodenal aspirates, which is, you know, invasive. So most of your patients aren't going to do that, but there's other testing we can see it on. IMO, I already told you, associated with constipation, and then hydrogen sulfide associated with diarrhea, but could be some constipation, and the abdominal pain tends to be stronger there. Hydrogen sulfide is fairly toxic and very uncomfortable. And let's see, there was a paper, a research paper that came out last summer, which a lot of practitioners are like, we already know this, but it's always nice to see it validated in research. So came out summer of 2020 and really showed how different the environment is in the small intestines. It looks dramatically different from the large intestines. And they looked at kingdom, phylum, and genus of bacteria. So for the practitioners who want to geek out, you know, by all means, pull that up. And then the standards for SIBO protocols, I'm going to actually go over it with you, but paper came out, Mark Pimentel published in February of 2020. Before that, we had sort of North American standards for testing, but that was the most recent one, February of last year. Okay, here's another view of the 3 gases. I took this graphic from the Trio Smart breath test website, which I'll mention that as one of the testing options. But this is just a nice little summary of what I was telling you. And they are using the IMO, intestinal methanogenic overgrowth, but a lot of people are just going to call it SIBO, methane dominant. So be flexible with both. Archaea, single cell organism, and like we said, not a true bacteria, and we've learned different things about it. For the hydrogen sulfide, it's SRB sulfate reducing bacteria, using those carbohydrates, using hydrogen, and then releasing hydrogen sulfide gas. And then depending on why do you want to test? Well, first of all, it's nice to confirm what's going on before you put together a protocol, but the protocols are very different depending on what you have, including, you know, the food. And I get into this even deeper in Functional Medicine Academy or if I'm doing private coaching with practitioners, because we're going to do a lot today, but I get into like, the role of metabolizing B vitamins and homocysteine and methylation and genomic testing and MTHFR SNPs and things like that for the practitioner level. All right, let's talk about testing options. So the small bowel aspiration is the gold standard, but it's invasive. It's mostly used in research. Not perfect either, even though it's the gold standard. Remember, the small intestines is very long. So, depending on where you're getting your aspirations, you can miss things. So we do rely on the SIBO breath test, and the standard, some people do a 2-hour, some people do a 3-hour. Really, a 3-hour is preferred. And I like lactulose. Some practitioners do both. Lactulose is not absorbed by our body at all, so only the bacteria or archaea is going to eat it. Whereas glucose, our body does also absorb it, and the bacteria loves it, but it tends to pick up SIBO more in the earlier part of the small intestine, so you can get a lot of false negatives, but sometimes it can be more sensitive. So that's why some practitioners do both, but otherwise we use lactulose, and we want a 3-hour test. That's for multiple reasons. With someone with slow motility, if you don't get that 3-hour test, you might miss it. But I also like to see what's going on in the colon, so that's why I want a longer test. The Trio Smart Breath test is new. You can use lactulose or glucose. We use lactulose again, and the first one just does methane and hydrogen. The second one does both and brings in hydrogen sulfide. Now, the IBS blood test does not confirm SIBO, but it can confirm IBS, post-infectious IBS, and there's a good chance of SIBO, but it's very helpful to know if that's there, and it costs a lot less to get that test versus diving into those big, expensive, invasive testing. So hopefully that will get utilized more and more in clinical practice. It's a test we order for patients as needed. And then things like oats test, an organic acid test with urine metabolites, Cyrex Array 22, the GI map stool test, which is an advanced quantitative DNA PCR test. Those are excellent tests, and you can see signs that indicate SIBO, but they're not diagnostic of SIBO, but they can still be very helpful, especially like if you're looking for that Klebsiella overgrowth or that H. pylori overgrowth. And then if you can't test, again, you really want to try to test, but sometimes for some reason or another, testing is not an option. So some criteria you could use that means SIBO's quite likely is, one, bloating that is worse by the end of the day, that, oh, I feel pregnant at the end of the day. You might trial a low FODMAP diet and the patient feels better. And then if they take probiotics, they feel worse. So those 3 criteria can be helpful. All right, so here's an example, and this uses the 2017 North American breath testing guidelines, where you have a baseline, and for hydrogen, if it gets 20 parts per million over that baseline by the 90-minute mark, so S5 on here, it's positive for hydrogen. Now, if someone's quite constipated, you might want to consider it all the way at the 120-minute mark, S6, if they really have slow motility, and you already know that. And then methane is considered positive at any point in the test if it's above 10. So that's sort of the criteria. You can see this patient was had quite an overgrowth, even higher than the lab would measure. We don't know what the top was, but it was 81. After an elemental diet with this patient, methane's considered the toughest to get rid of. But after elemental diet, that 81 or higher was down to 44. So that was a big leap ahead. And you can see the hydrogen's quite low, but again, that hydrogen is going to be used to produce all of that methane. So it's not uncommon that as you bring the methane down, you might see those hydrogen numbers spike up. And before we had TrioSmart, if someone had classic SIBO symptoms and these markers seemed mostly flatlined across the board, we were surmising that hydrogen sulfide might be a possibility. But now we can test with it, and I will show an example. Here's a methane dominant. Some docs will say classic methane dominant SIBO. They hit 13 by the 90-minute mark. So 90-minute is traditionally about when you're moving from the small intestines into the large intestines. And thank you for asking questions. I see that Katie's going to collect all the questions and we'll get them all at the end. But this could also be, you know, what we call like a methane bloom. You can see it goes up quite a bit, you know, towards the colon, or again, that IMO, that new terminology. And this was a patient at classic constipation. Here's a patient who was positive for both, right? They had an overgrowth of hydrogen and methane. These are the instructions for the new TrioSmart test. And, you know, the diet, most of them allow, so when you take this test, you have a specific diet the day before, and then you fast for about 8 or more hours overnight. And it's usually meat. If you're a strict vegan, like you could do tofu, but meat, eggs. Like if you're a vegetarian, focus on the eggs. And they allow white rice. I usually encourage my patients to skip the white rice. And just, you know, it's one day, and it's not about going hungry. It's one day, have the protein. And if someone was a vegan and they absolutely did not want any animal protein, they wanted as clean a test as possible, so they weren't going to do tofu, you could just fast for one day. It's not the end of the world. Stay very hydrated, right? And then you do the test the next morning, follow the instructions. Besides the test kits, we give some extra instructions just to help with some tips. So you can perform it quite well. Here's an example of the TrioSmart. So you can see hydrogen, methane, and in this case also hydrogen sulfide. This patient was positive for all 3 gases. Just a few things. Wise practitioners are going to read between the lines. They're not going to just look at a marker just for how it is, or just a positive or a negative, because sometimes something can look negative. Like I said, and maybe it's that 120-minute mark, but someone has constipation, slow motility. And so there's definitely an art and a science to interpreting these tests. But I also like them to pay attention. Where are things happening? How long into the digestive process? Is there more than one gas present? Always, you don't just go by a test, positive or negative. You always have to relay it back to that clinical presentation. And then you have to weave it in, the functional medicine perspective is you have to weave it into everything that's going on with that patient. What is the big picture? Here's a SIBO Flowchart. These were variations from Dr. Mark Pimentel, Dr. Seebecker, Sandberg Lewis put together. Siobhan and Dr. Seebecker put this together. Very helpful. I'm going to show you a different one, but sort of a flow chart for, treatment protocols and moving through the process. The SIBO diet as a whole, like I said, it does not resolve SIBO. That's very important to know. It can be helpful, especially if you're uncomfortable. So some people, the low FODMAP diet will make them feel a lot better at managing symptoms. But hydrogen sulfide, actually often a vegan diet or low sulfur diet works better. But FODMAP's the one used most often. It's an acronym, so if you're not familiar with it, it's describing different classifications of fermentable, foods. And I'm going to show you another list. This graphic was taken from Monash. So Monash University, they actually have an app, and it can be very helpful for, hang on one second, I gotta get my team member back in. It can be very helpful for identifying foods. But the FODMAP diet, it's not one that you want to ideally be on long term, because or these low fermentable foods. Hang on, let me just make co-host here. Okay, Katie, we got you back in. Because again, we don't want them in the small intestines, but your large intestines does benefit from fiber and fermentable foods. So if you starve it too much, you're going to have a whole host of new problems. So that's not the healthiest thing. Here's a graphic from Monash listing high FODMAP foods, sort of a shortcut to it on the left, and low FODMAP foods on the right. This is our version, which you can get online, and we certainly give to patients. It's multiple pages. And the reason we do this is because we get so many complex cases. Of course, we like the simple ones, but we specialize in very individualized care. So we have a lot of complex cases, and we needed a highly, highly sensitive column for people who are absolutely miserable and hugely reactive to start with. And then a lot of patients, they can eat out of both green, the highly sensitive and sensitive right to start with. But otherwise, the really tough ones might need to start with highly sensitive. As they're feeling better, move into the sensitive column. As it gets better, move into the yellow, start testing those foods and whatnot. Let's see, what else was I going to tell you about this? I feel like I'm going to save this one for later. I'm going to give you some interesting new tips and tricks for going after methane. So hopefully, let me just copy these couple notes I wrote. If I forget to tell them, whoops, I went too far. If I forget to tell them later, I'll bring them in then. All right, let me jump back up there. We were right there. So just another page of our SIBO diet version. Okay, so I'm going to show you a graphic. Let me move through it slowly, and then you'll see the piece. So this is for SIBO Care as a whole. On the left, you can see you've got the person, they're bloated, they're miserable, they're going to have a host of other symptoms, not happy. Ideally, pre and post SIBO testing, so you can confirm you really have SIBO, you can monitor the progress and know as you move forward. And then the first thing you need to do, you have to resolve digestion. If we don't have good digestion and good eating habits from mouth to stomach, you're not going to have good habits moving forward. So we need good digestion right at that stomach level. Some people are like not even chewing their food and they're sucking in too much air. We need to deal with that. Meal spacing is a free trick that is brilliant. If someone has blood sugar balancing issues, they might need to eat more often in the beginning, and you need to resolve the blood sugar balancing issues. So maybe they're eating every 2 to 3 hours, but as you resolve those issues and they're able to add more gaps between meals, the goal is to have 4 to 5 hours between meals. That can be life-changing as with SIBO. So we'll explain more about why you want that, but dramatic shifts. And then structural issues. If there's structural issues, they might need a chiropractor or an osteopath or a massage therapist or a physical therapist or acupuncturist or more than one in their life. Depending on what's going on. There could be some pelvic floor issues, there could be scar tissue, you know, things like this. So you want to be dealing with that. The next step is doing a SIBO protocol. So we're going to go through this in detail. Antibiotics is an option. Herbal antimicrobials is an option. Elemental diet is an option. So I'm going to walk you through each of those in detail. Dealing with stress. having techniques for it, dealing with vagal tone. And again, if you don't resolve constipation, nothing's going to work. We have a great handout about constipation that we use with patients and practitioners. It's actually more complicated than people think. And certain phases you have to move through to get it resolved. All right, you want to resolve the slow motility. So we're going to talk about prokinetics and what it takes to keep things moving. Hang on. Katie, someone might be unmuted if you can snag them. And then if there's fungus, if there's mold or yeast issues, to address that. And then finally, other issues. For the person who's asking, how would this show up out of nowhere? It might feel like it was out of nowhere, but there's always a reason for it. And so I covered that in the beginning, but the things that contribute to it, you know, low stomach acid, food poisoning, nerve damage, hypothyroid, things like that. Okay, so, and lastly, any hormonal issues playing a role, again, thyroid, cortisol, dysbiosis in the colon, leaky gut, intestinal hyperpermeability, making sure, you know, just like good fences make for good neighbors, we want good barrier health in the body, good barriers in the gut, in the lungs, in the brain, and then preventing relapse. So this is the graphic right here that we're going to be working from. All of this is involved in proper SIBO care. Now let's start breaking down each section. So for digestion, often betaine hydrochloride, pancreatic enzymes, ox bile salts. You might not need all of them, but whatever it takes, you want that patient to be able to properly digest protein, carbohydrates, and fats. My personal favorite, Katie, maybe you can write it in the chat and post the Designs for Health link. We always give people a discount, is Digeszymes. I like Digeszymes because it has all three of these in it. It works incredibly well. Sometimes people with a history of acid reflux, usually 2 per meal will do it for you, but sometimes they have to go as high as 3 or 4 a meal, just because they're so depleted. Meal spacing, 4 to 5 hours. I already said that. Complete digestion. You want to allow for the MMC wave. We're going to talk about that in more detail in a minute, and also for blood sugar balancing. So meal spacing is essential. For structural issues, there may be an anomaly in the gut. Some people have redundant colons or tortuous colon, or they just seems like there's a hairpin turn, or, you know, everything's sort of jammed in the pelvis here. Maybe there was a birth injury, or maybe there's a congenital anomaly. These things must be considered. So a good practitioner is going to look at all of these, and it doesn't matter if that practitioner doesn't do all of them. They need to understand the role it plays and give proper referrals as needed. Just briefly on blood sugar, if you want to see more about blood sugar balancing, that's that chemistry of food link. So Katie, if you could post that again, watch that on a later date. I believe it's early in the video. You can always fast forward and rewind to the sections that interest you. But early in the video, we talk about blood sugar balancing in detail and the roles that hormones play with it. So that needs to be addressed. All right, let's talk about the migrating motor complex. So for some of you, that's a whole new phrase, MMC wave. Those of you who've had SIBO for years, or the practitioners who've been treating it for years, you know it well. But the MMC wave, it has a neuronal component to it, and also a peristalsis component to it. So smooth muscle contractions, peristalsis. It's controlled by the central nervous system and the motility hormone. But what it does is it propels food from the stomach into and through the small intestine. So it's an important wave. Some people describe it as a housekeeping wave, and it's certainly something you need to address in SIBO, and quite often for patients who are dealing with acid reflux, that can be an issue too. Or, you know, slow gastric emptying. But it happens about an hour after you eat, and then it can take up to 90 minutes or more to complete. So this is why we used to think 3 hours between a meal was enough, or maybe 4, but no, really 4 to 5. This is the research we've seen out of Cedars-Sinai. And if you pop a little snack in, you're gonna turn that wave off. So that's why I say meal spacing is such a powerful tool. And you know, that blood sugar balancing piece, in order to not starve, you need to have enough protein and fat at the meal that you're sustained. You have energy. This is not a struggle to go 4 to 5 hours between a meal. So yeah, you don't want to pop a little snack in between. You're going to pour that, turn that wave off. And we do 2 series of that wave in the evening too. All right, let's talk about a prokinetic. If you haven't heard that term, not a probiotic, a prokinetic. So the prokinetic is an agent that stimulates the MMC wave, for example, but it improves GI motility. So, and SIBO in most cases is an issue of slow motility. So we use prokinetics to help improve that. And there's some pharmaceutical options. We try to use the natural options whenever possible. One of the best pharmaceutical options is LDN. Yeah, Katie, if you can put a link to the last time we did the SIBO video, it's on the video tab. If you put the link to that, this video, of course, this class is going to be more current, but that link has the SIBO diet, so you can download it there. Okay, so LDN stands for low dose naltrexone. Ask me if you're not familiar with that, ask me in the Q&A. We'll talk more about that. But that is like a weak prokinetic, but it can still be helpful with SIBO patients that have like additional issues, chronic fatigue, fibromyalgia, autoimmune conditions. So it's most helpful when there's other things going on. Procoliprid or Migrating is used. Some people don't like it. For one, it's a newer prescription. It can be quite expensive. So you need a doc who's going to fight with insurance to get it covered. And then some people don't like it because they feel like they have cramping and loose stools. So sometimes it's just a matter of playing with the dose. But anyway, there's some really good natural options. Before Procoliprid was a better prescription, the 2 other prescriptions there were used, but they had increased cardiovascular risk. So that certainly was not beneficial. Now, the natural options, Iberogast is listed. I don't think that's very effective as a prokinetic. I think it's better for just sort of helping with gas. Ginger is certainly one of the components, but I like blends that include ginger with a prokinetic, including Prokine and Modal Pro. Those are the 2 I use most often. Now, Modal Pro just has 4 ingredients. Ginger, so if you take it, I describe it like if you've ever had a glass of red wine and drank it too fast and you feel this like warm rush in your chest, you're not having a heart attack, that's that ginger. And usually just drinking more water and you'll be fine, but you can get this ginger flush that can feel a bit dramatic if you're not prepared for it. So Modal Pro has ginger and I believe acetyl L-carnitine, 5-HTP, and vitamin B6. Prokine has all of that and more, and the 5-HTP is about 3 or 4 times as high. So it's a stronger prokinetic. Now, patients who are on SSRIs, this might not be an option for him, but the 5-HTP is in there because of the role serotonin plays in our gut health, including our motility. So it's trying to address that neuronal component of slow motility and the MMC wave. The other ones that are listed there, I listed them. You can see them on Dr. Seebecker's site. I don't think they work as well. That's why I don't use them. So tried them, don't like them as much. And the way I typically use Prokinetics Modal Pro, by the way, is about 1 after lunch and 2 after dinner. I know I'm going to answer questions at the end, but I just saw this, so I'm just going to say it real quick. When you see strep overgrown on a GI map, yes, there's absolutely a connection to SIBO. So strep will often get overgrown on a GI map when constipation or SIBO or insufficient digestive capacity, such as low stomach acid, is present. And then once strep is overgrown, it can often lead to loose stools. And strep loves mucous membranes, same strep when we get strep throat. It can colonize in the skin. So sometimes those patients are more likely to have rashes or eczema or actually particularly acne. So that's the rule. So if someone has an overgrown strep, is that diagnostic for SIBO? No, but a darn good sign that it's a potential. All right, let's go in the next section. SIBO protocols. So let's talk about what to do here. So antibiotics, herbal, microbials, and elemental diet. I'm going to break each of them down, and then I will show you a little bit more about stress and constipation. So we're going to go in detail. All right, here's the antibiotics. So I gave you this list here. This is one of the antibiotic protocols for when methane is present. We have a whole sheet that we give that lists multiple antibiotic protocols and the research behind it. But using rifaximin or Xifaxan is ideal because, and it's used with all 3 gases for SIBO, but that's ideal if you're going to go the antibiotic route because it's not as readily absorbed into the bloodstream. It's mostly kept in the gut, but rifaximin alone can be helpful for hydrogen and hydrogen sulfide cases, but not for methane. So in that case, you're going to add metronidazole, Flagyl, or neomycin. So that's more of a broad antibiotic. So we have to watch. It's very common for people to get a yeast overgrowth. Anyway, I put the doses for both of those, and it's typically 14 days. So if you're going the antibiotic route, you want to talk to your prescribing doctor about this and make sure you're getting a good protocol. It can be very expensive. I had patients that were spending $3,000 on a round of rifaximin, $1,000 easy. So that's not good. If you have your prescription, you can order from Mark's Marine Pharmacy or Canada Drug Stop. Both of those places in Canada, you can get rifaximin for about $100 or $200. So Mark's Marine Pharmacy or Canada Drug Stop. It's still, you still have to have a prescription, all the proper procedures, but you can get it filled that way and they will ship it to you. Part of that protocol, that's very involved. So we have GI docs who refer to our office. They may or may not do the SIBO testing. Sometimes we have to order it. Sometimes they do it. And then they'll give the prescription. But quite frankly, they don't have the time to walk the patient through all this. So they send them to us because they need multiple visits and there's a lot of education. So they don't want to just dive into taking the antibiotics. They want to be ready for it, which means they have to get all these things lined up. And then they say, okay, Monday's go day, right? So they need both antibiotics. And then we use partially hydrolyzed guar gum, PHGG, which most days if a SIBO patient were to take it, they'd feel very bloated and not like it. But just during the antibiotic treatment, the theory behind it is well-fed bacteria is easier to kill off. And the antibiotic treatment is definitely a gut bomb, right? So they do 5 milligrams a day of the PHGG. Says 5 grams, but I believe it's just 5 milligrams. And then we typically give an antifungal because they almost always get a yeast overgrowth. A lot of times they had yeast already, but just, you know, you hit heavy antibiotics, you're wiping out too many strains, the yeast will overgrow. So the antifungals I like to use best is oil of oregano, which you can get from Designs for Health. Katie can put that link in there. It works very well. I've used so many of them, but they're soft gel caps, and usually 2 a day while on the antibiotics will work. If I'm really trying to go after fungus, you know, separate from this, I'll often do 4 a day. Or Colorex. If you're not familiar with Colorex, we have to order that for our patients, but we're happy to do so. Colorex is out of New Zealand. It's red leaf horopedo and works extremely well as an anti-candida agent. And then a digestive aid with their meals. Digestimes, again, is my favorite. And then a Prokinetic. So we typically use Modal Pro or Prokine. And then after coming off of the antibiotics, switch to low FODMAP, and keep the digestive aid, the antifungal, the Prokinetic. Now add in herbal antimicrobials. We use alicillin. So a lot of SIBO patients, if they eat garlic, like garlic and onions, they're going to bloat, right? It's a high FODMAP food, but alicillin has the active ingredient. You can use it medicinally. It's the active ingredient in garlic, works very well against methane. And then I'm going to tell you some tricks that not a lot of people know about, because methane is definitely tougher to get rid of. But usually 2 alicillin a day, ideally on an empty stomach, works well. Sometimes people are like, oh, it tastes like garlic, I don't like it. So you could do it at the end of the day, or, you know, drink more fluids. If you have to do it with a meal, okay, but on an empty stomach is ideal. And then post-test, some practitioners will test right afterwards. They end antibiotics, day 15, they're post-testing. Quite frankly, I like to do a test 2 weeks later. And the reason is because if, you know, everything can look really good the next day. I want to know what's happening 2 weeks later as they're returning more to normal life. What difference did we make a couple weeks away, and what's still left? All right, so some docs, a patient will come in with IBS diarrhea, and they will just give them rifaximin, and they might improve quite a bit. They won't do any testing. So rifaximin can be used just with hydrogen and just with hydrogen sulfide. A lot of docs will use rifaximin with bismuth, maybe just even Pepto-Bismol 3 times a day if hydrogen sulfide is present. About 50 to 75% of the breath tests will be negative right after doing a round of rifaximin. Not uncommon to need multiple rounds, which is why it is not worth paying a premium for this. Some people feel great on the antibiotics and love it. Some hate it, feel miserable, say they'll never do it again. So thankfully, we have multiple protocols and not uncommon to need multiples. All right, let's talk about some herbal antimicrobial protocols. Now, one thing is, and Dr. Pimentel was working on this, but it didn't get past like the 2nd stage of drug testing. But he did discover that a statin actually turned off the enzyme involved in this methane production. So he was trying to make a drug specific for methane dominant SIBO, or what he's calling IMO now, right? Intestinal methanogenic bacteria. That has not gone through yet. What we have started to use, just to be creative, so practitioners out there think about this, is red yeast rice. So if you're not familiar with red yeast rice, it is a natural statin. And it's quite dramatic. The one I like to use the best, if you can type this in, Katie, is called RYR Synergy. And I like that one the best. It's through Designs for Health. First of all, I love Designs for Health because they'll let me give you a discount. They have excellent quality and sourcing. You can order it right online. Their shipping's good. Their customer service is good. There's multiple reasons. And red yeast rice, their version of red yeast rice, it's very important because there's some ingredients in red yeast rice that can cause some liver issues. And Designs for Health specifically tests for both of those, the monoclonal and the citrulline or whatever it is, citrinin. I couldn't remember the name. So they specifically test that their red yeast rice doesn't have that in it. So that's important to me. But anyway, so that can turn off the same enzyme with methane production. So for your really stubborn methane cases, you might want to get creative and give that a whirl. Now, most of the cases, if you're using RYR Synergy, red yeast rice, you know, people are using it for cardiovascular issues, right? Elevated cholesterol, and they're taking 2 at night before bed. I'm super cautious, so I will test liver enzymes, AST and ALT, very inexpensive test. I want a baseline, and then as they're taking it, I will test them again. So I just want to make sure they're doing okay. But I will often start a patient with 1 red yeast rice Synergy only twice a week. Very, very low dose, right? Here, let me give you, this is actually a goat study, but let me just give you a link. I'll put it in the chat. So especially for the practitioners, there's one of the links to the study that talked about how that enzyme and specifically turning off the methane production. So for those of you who want to geek out on it, there you go. And methane, you know, there's a whole family of methane. On a GI map in the opportunistic bacteria section, you can see an overgrowth of the methane family, and it's specifically Methanobrevibacter smithii that is that culprit in constipation. All right. Oh, the other reason I use red yeast rice Synergy, besides the fact that Designs for Health has made sure that they have undetectable levels of the citrulline and the monocolin, is they also add CoQ10 in. So that's very beneficial. Okay, so back to some herbal antimicrobials here. Oil of oregano can be very helpful, especially if there's also fungus, but oil of oregano and alicillin, the garlic, so those 2 I use a lot. Those are, if you see in parentheses DFH, that's Designs for Health, you can get it right through the link. Highly recommend you work with a practitioner, but I know some of you are sort of like weekend warriors with this. I think in the long run it gets frustrating, but I understand. GI microbe X is also helpful, especially if some parasites are present. Probiophage, if you've never heard of phages, it's actually one of the oldest things on earth. If we grabbed a drop of water, there'd be thousands or more of it in there. And it's a virus, and it affects the bacteria, but does not harm human cells. And so it will go infect the bacteria, and it's sort of like clear cutting a forest. So the probiophage from Designs for Health has 4 phages that work well, particularly with E. coli strains, which we know is an issue in SIBO, and those in the family. Can even be helpful with H. pylori. And it has 5 probiotics. So that's why I say think of it as like this clear cutting process. And it's best if you keep that in the fridge. And rotating these agents, because we are talking about living organisms and they want to live. They're not eager to go, and we don't want them building up a defense. Yes, they're clever and creative, and they will try to do that. And then antifungals, I told you it takes longer. Methane's the toughest form of SIBO bacteria, archaea to get rid of, but you know, long-term, the Candida overgrowth, if present, takes the longest. And so I like to rotate antifungals. Let's say I was going after fungus. I'll often use oil of oregano, you know, maybe 4 a day, solid for a month. But then at that point, I'm rotating. And so I might use oil of oregano and Colorex and Biocidin and Undecalex, which is undecalenic acid orally, or Mega Mycobalance. And I'm informing the patient to rotate these and get 1 in a day, and to be purposely inconsistent with it, right? So they don't know what's coming. If it's a really severe case and the patient's gung-ho to be aggressive, then we might do 2 at a time. And with kids, if you see a pediatric population, which we certainly do a lot of, the Biocidin drops and sprays can be incredibly helpful. All these doses are adults though, so of course you have to change the doses for children appropriately. Okay, some topicals. So when you're dealing with SIBO, not uncommon, like I said, to have a yeast overgrowth, or even if not yeast, to have rashes, acne, eczema. Colorex Intimate Wash is amazing. Katie, if you can put our full script link in it, I have it highlighted there so people can get it. So you can order from Full Script, you'll get a discount and you'll see it. But especially those connected to our office, I'd rather have you email the office and have us custom.
Grab stuff, I'm hungry.
Oops, we got someone unmuted. If you can snag them, that'd be awesome. But yeah, we'll put the Full Script link for you if you need it. Otherwise, you know, ordering through the office is better and easier, and typically less shipping. All right, let me see. I can't see who's unmuted. Maybe Katie can catch it. All right, so if you're not familiar with it, that is the red leaf Horopedo, which we use orally, but this is a cream and a wash. The wash can be just kept in the shower, in the bathroom, can work incredibly well topically. When you, practitioners, this is really for you too. Oxacell SE, you can get that through our Full Script link, or practitioners, if you have a practitioner account, that's through Apex Energetics. It's a cream, antioxidant largely. That can be helpful for really stubborn skin issues to rotate in. The skin issues are sometimes what motivates people to come in. So you could have someone with acne or eczema come in and they're actually a SIBO patient, and SIBO is nowhere on their radar. They're not even thinking about it. They're just upset with eczema, or they're upset with pimples, right? But the really stubborn cases, having more than one topical can be helpful. It's really an internal game, but we do need some topicals. And often skin's the last thing to heal. You know, you're going to be working on the gut and the gut lining, and that's improving, and the skin can be the last thing to heal. Sometimes these things, by the way, get worse before they get better, and that used to be described as like a Herx response. And why would people say that? Well, now we know there's a physiological reason for it. You know, bacteria, for example, release endotoxins, you know, lipopolysaccharides. Gram-negative bacteria release lipopolysaccharides. Think of it like a skunk having a spray, or a porcupine having prickly needles. It's part of their defense mechanism. And so bacteria does the same thing. And that's part of what makes us feel miserable. Well, when you kill them, I describe it as a Shakespearean 7-act death scene. They don't go quietly in the night. You kill them off, they release these toxins too. So it's not uncommon to sometimes see an increase in symptoms. So to be prepared for that. Some days will be better or worse than others. And we'll talk about if it's too easy or too hard, what that means. All right, and I listed grapefruit seed extract, GSE. I use Nutribiotics, which you can just get over the counter like Amazon. It has natural antibiotic, antifungal, antiviral properties. You do want to use it as an antibiotic. It's not something you take long term. I never have patients use it for more than 10 days in a row, but it's a great inexpensive trick to have up your sleeve. It's so powerful that you never want to put it, so we'll use it orally, topically, in nasal sprays, but you never want to put it topically directly on the skin. You need a medium. So coconut oil can be good because that also has some, you know, antifungal, antibacterial properties, and you can use some drops. And sometimes you need to alternate these. Prokinetics, Modal Pro, and Prokine are my favorite. Those are the brands for them, and I gave you typical doses. This is all under SIBO Herbal protocols. Some of these you might not need at all. You certainly don't need all of them, but that's where your practitioner, you know, really is your partner, and listening to you and using testing and figuring out what you need and making sure something key isn't missing. GSC is grapefruit seed extract. Okay, let's talk biofilm busters and binders. And I'm going to show you a slide on it now, but let me just describe it really quick. So we often give our patients notes called too easy and too hard. If we're working on something with gut health, and SIBO is certainly a gut health issue, if it's too easy, that's a problem, because there should be a noticeable difference. Like I said, some days are going to feel crummy. And when you kill this off, you have to poop it out. So if someone is taking, you know, a couple kill agents and they feel nothing, it's not working. And they might have biofilms. So some of you know what biofilms are. A lay version is, you know, I describe them like apartment buildings. This is where the bacteria is hiding from your body's natural defenses and hiding from the supplements or the antibiotics or whatever treatment method you're using. So you might need an agent to break down those biofilms. That's a good thing to know, but it's also a pain too, because when you break down a biofilm, you're going to have an increased flood of that bacteria into the body. So it's going to feel sort of crummy. So I really like the patient to be very, very empowered with their dosing. And that's why I say 1 to 4 a day based on tolerance and response. If they're taking a kill agent, they notice nothing. We're adding a biofilm buster, and 1, they feel nothing, and 2, they feel nothing. They get all the way up to 4, and that's where they notice it. All right, that stuff was really protected. That's what it took. Otherwise, a lot of people won't need a biofilm at all, or maybe 1 a day. And same thing with too hard. If someone's doing a protocol and they feel miserable, like every day is miserable, they feel like they have the flu, or they've got diarrhea all day long, they're just living in the bathroom and it's for 2 weeks, that's too much. It shouldn't be like that. So I want to empower them to half the dose, take a break, give it a break. Maybe we need to do a couple days, let the body sort of adapt, clear things, and then bring it back in, right? Or sometimes we need to give a binder, because when you kill these things off, besides the fact that you have to, poop it out, there's the toxins to deal with. So now you've got your liver involved. Well, what's the shape of your liver? Do you have a fatty liver? So many people do. It might not be, functioning properly. Might not be diseased to the point that you have abnormal liver enzymes, but you might have, a fatty liver. Your kidney is going to be involved. You need to stay hydrated. So a binder, for example, I gave you a list there of a binder. Very, very short-term use, because I don't want to swing someone to constipation. But the binder I'm recommending, there's 2 versions there. It has charcoal in it, bentonite clay, some zeolites, and things like that. So that can help to sort of bind up the toxins and help reform a stool. So I listed 3. The first 3 are biofilm busters. Interphase Plus and Biofilm X are pretty well known. You can get those through Full Script. Nattocerezyme is Designs for Health. That is the creative use of that, because nattocerezyme is more typically used for people who are at a clot risk, right? It's thrombolytic, it'll break up clots, but they're enzymes, and the enzymes can also help break down biofilm. So if you have a patient who's dealing with both, that might be a good choice there. Probiotics. A lot of times we're not using probiotics in the beginning of SIBO protocols. It just depends. Everyone's individual. The ones I use most often are ProBiomed. That's a Designs for Health one. It has the top 10 research strains. And anytime you get a probiotic, this is especially for the patients, you want the specific strain listed. There should be numbers after the ingredients of which probiotic it is. If you don't see that, then they're not really using the ones used in research. You don't really know what you're getting. So a lot of times the over-the-counter ones, when you're disappointed with how it works, for those who don't know, like the New York Attorney General in 2015 sued the top 4 supplement brand makers in America. Well, that covers almost every supplement you would buy over the counter, whether it's Whole Foods or Costco or, you know, a pharmacy or whatever. You know, and the reason they sued them is because they didn't have the ingredients on the label. So that's part of why we use these physician grade, besides the fact that we work so hard to get educated, know what we're doing, have tools we can count on. But if I'm going to recommend something and it doesn't have the ingredients in it, I mean, forget it. I'm just not even going to mess with that. What a way to be frustrated. And before I went back to school and learned all this, I did a lot of that sort of like guessing and trying to do it on my own, and just spent really like $10,000 on supplements that did nothing. So I'm very selective in my choices. I've worked with 30 different brands. So when I say I like something, I really like it, and I've tested it a lot. All right, so the first 3 are biofilm busters. The last one is a form of a binder. Probiotics, I mentioned ProBiomed, which you can get in multiple strains. Megaspore Biotic is a soil-based probiotic. There's another one called, by Designs for Health, called Prebiospore. If you could type that in, Prebiospore is helpful. By Zymogen, the ProBiomax, not the lean, but just the ProBiomax Plus or the regular ProBiomax, that helps with motility. It has a strain in it. It's a bifidobacteria, and the number you're looking at the end is HN019. So Katie, if you can type that in, HN019, and that Zymogen strain has it. That strain is shown in research to shorten time moving through the bowel. And it's not uncommon that at the point that I have patients on probiotics, that they will have 2 or 3 of these, and same thing, I want them to mix it up. Get 1 in a day, but that's the closest to mimicking real life, because unfortunately you don't just like take a probiotic and everything's repopulated. Wouldn't that be lovely? It doesn't work like that. It just helps as it's moving through the gut, but it moves in, it moves out. That ProBiomax Lean I mentioned has a different strain in it that is specifically helpful with leaky gut. So anyway, those are the ones I use the most, and that is why. And we use Saccharomyces boulardii quite a bit. You can get these blends with it or without it, because there's some cases you don't want it. But Saccharomyces boulardii is particularly helpful with someone who's having diarrhea. All right, still in the natural immune support. I'm just going to sort of show this to you and move on. Tegracell colostrum is wonderful, but it is a dairy product, so that doesn't work for everyone. But that's Designs for Health. If dairy is not an issue, you can get that. It's going to be more affordable, but you're basically getting immunoglobulins, IgG there. And then for those who need dairy-free, sort of like what I got in the hospital, except I had the really expensive human version, we now have supplements that are what's called an SBI, a serum-derived bovine immunoglobulin. It's a blood product. but it's dairy-free, and Mega IgG 2000 and SBI Protect. Those two we use the most often. SBI Protect is nice because it comes in capsule or powder form. I listed some stuff for immune support. I'll mention Hepatotone Plus briefly because it has some good liver support, some antioxidants, some medicinal mushrooms, including cordyceps, which can be particularly beneficial with those dealing with thyroid issues. And then GI Revive is my favorite for leaky gut because it has 15 ingredients in it. Instead of giving people multiple bottles, I'm giving them one thing. The only downside is because it has so many ingredients, it does have a high pill count. It's 7 a day, ideally on an empty stomach. Or if someone's willing to use a powder, it's 1 scoop of powder. And then if there's an ingredient in there they can't handle, then you pick and choose and do isolated bottles. But otherwise, I have a lot of success with GI Revive. That's a Designs for Health one. You can get it right through the link. I love that. Let me just make a note here. If someone feels worse with supplements, not just food, but with supplements that increase sulfur or have sulfur involved. Yes, Probiomax Lean for the leaky gut, you got it. So like, let's say cysteine, glutathione, MSM, bile. If someone feels worse with those, that can be a sign of hydrogen sulfide overgrowth. So that's a little tip for you, especially all the practitioners on. Okay, let's keep going. Still a lot to do. All right, there's my 2 easy, 2 hard instructions. I already covered it, so I'm going to keep moving, but there they are. You can take a little screenshot if you want, or remember you're going to get the recording. Okay, third protocol option. We covered antibiotics. We covered natural antimicrobials. Now we're in the elemental diet. So for those who don't know, this is different than elimination diet. Elimination diet is great, is not SIBO specific, completely unrelated. This is the elemental diet. The one I use most often is Physicians Elemental Diet, dextrose free. And it's corn free also. So the maltodextrin is from, I don't recommend 40 days. We'll talk about that, but definitely don't recommend 40 days. And I'll tell you why. It's not from corn, it's from tapioca. So 14 to 21 days, 21 days has been shown to be about 85% effective. I already showed you that lab that we had such a big change. That was only 14 days, by the way. So in 14 days on elemental diet, methane went from 81 to 44. The hardest part about elemental diet is you're not having any other food during that time. That's weird. That's weird in society to not eat. So you have to prepare the patient for what that is like. Weight loss is very typical, and a lot of patients, especially those with constipation, they have weight hanging on them because of SIBO, and they're thrilled when the weight comes off. Now, if we have an underweight patient who's more prone to diarrhea, that can be a problem, and you need to get enough shakes in for them, or you need to add something like MCT oil so they're getting enough calories. But MCT oil can also cause diarrhea, so you got to be careful with that, but we don't want them to lose weight. When I have patients on the elemental diet, I'm having them email the office. So aside from visits, I'm having them email the office more often, twice a week, with how they're feeling, how many shakes they're having, and what their weight is. Okay, very important. Oh, and their number of bowel movements. So, so all 4 things they have to email twice a week. We have research, and I've seen this happen clinically. We have research that shows that after doing the elemental diet, there's an increased risk of getting C. diff, just like taking antibiotics. It could happen with anything that kills off a lot of bacteria in that way, but specifically we have research with the elemental diet. I have had elderly patients in particular that had SIBO and wanted to do the elemental diet, and I required the GI map first because I wanted to make sure they did not have SIBO. I mean, they didn't have C. diff, or they didn't have the toxins, like they weren't high risk for it. So that's how I handle that. And that's why you don't want to do elemental diet long term, because the whole point of it is you're getting these really broken down nutrients, you know, and protein into amino acids, carbohydrates, essential fatty acids, and it's getting absorbed in the proximal small intestines. So you're starving the rest of the bacteria. It's very effective, but we do not want to starve the large intestines long term. We're going to cause bigger problems. That's when C. diff can happen, or you can make a worse dysbiosis situation. So elemental diet is brilliant, but you need to work with someone educated to guide you through it. There's a homemade version you can get from Dr. Seebecker's side. I think all the homemade versions are disgusting, so I would much rather use the physician's elemental diet. I believe they're coming out with a new peach flavored one. I don't think it's out yet. And you can change the flavoring a bit. All right, still a lot of slides. I'm going to keep going, and then we're going to dive into our Q&A. I talked already about stress and vagal tone. You can see some of the issues that come up with low vagal tone, the reasons you want to improve it, and then the things that will help it. So deep breathing, meditation, laughter, singing, chanting. I'm a big fan of chanting. Anything that vibrates the throat is like CrossFit for the vagus nerve. Cold exposure, fasting, some probiotics feeding the beneficial bacteria can be helpful. All right, constipation. Here's, if you want to take a screenshot, do it. I give a much more detailed handout, and for practitioners who go through our Functional Medicine Academy, I really walk you through this, because quite frankly, there should be no constipation case you can't solve. And we've had patients come in where they had 3 decades of constipation. It's a mess. You can't get well if you stay constipated. And a lot of people don't think they're constipated because medically they say, well, if you poop 3 times a week, then you're not constipated. I consider once a day bare minimum. And I just say, like, when you had a baby, did you only change the baby's diaper 3 times a week? Or do you only take your dog out 3 times a week? No, it's baloney. You take them out 3 times a day. You eat, you poop, you eat, you poop. And I consider healthy 2 to 3 bowel movements a day with ease. You don't have to think about it. We don't want diarrhea. We don't want constipation. A lot more I could say about that, but that's a whole nother class. But I did give you this list because these, from insufficient nutrients, insufficient digestion, poor eating habits, lifestyle, hormonal, bacteria, neuronal, structural, and underlying issues. This is the triage I have created, the clinical ways to move through resolving constipation. Because quite frankly, you might solve it with line item 1 and you're done. But your toughest cases, you might move through all of it, but it can get resolved. And especially for SIBO, must be resolved. Okay, so slow motility, that's the next phase of our overall SIBO care. Prokinetics, we talked about that already. So needing a prokinetic agent, that's certainly going to be in the SIBO patient's life for a while. Some people long-term, but definitely for a while. And resolving fungus if it's there, whether mold or yeast, make sure you resolve the fungus. So I want to give you just a couple slides on it. It's not the topic for today. I did talk about fungus and yeast in that 4th class. So it's on our video tab. And it's the one where I did like hormonal and gut issues together. But you can see a lot of the signs and symptoms, especially people who have sugar cravings that are worse at night. The yeast seems to be more active at night. Some of the common causes are on the right. And then the last piece on our SIBO Care protocol is resolving other issues, hormonal issues, dysbiosis, and leaky gut, and preventing relapse. Let me show you a few slides on that. For the hormonal issues, the reason we care about it, first of all, the patient might have a lot of other signs and symptoms, right? They might have some weight gain, some low mood, some hair loss, some low libido, but hypothyroid is going to contribute to or perpetuate SIBO if they have it. And hypercortisol can do the same thing. And they're often overlooked. And so you need a practitioner who understands it. Now, my favorite test for sex hormones and your adrenal hormones is the Dutch Complete. Love that test. I'm going to show you just one page of it. For practitioners, Katie, maybe you can share this. I did a practitioner webinar with docs all around the world on Dutch test. And I'm not affiliated with any of these labs or supplement companies, just so you know. Absolutely zero affiliation with any of them. So I'm really just sharing things that I've tested over the years and learned what works best for practice and patients. So there's a Dutch training video. I don't have it like publicly available. It's sort of a secret link. So now you have the secret link. But I was teaching practitioners how to use the treatment booklet, the guide, with reading the tests. So there's that. And then thyroid. So patients who are listening, if you get your sex hormones through blood, it's not that great. That's not the best way to test your estrogen, progesterone, testosterone. You're really only going to see something off if it's really off. So the Dutch is much better because it's a urine metabolite, simple urine test you do at home and sent to the lab. You're going to not only see levels, but you're going to see the metabolism and clearance. Especially women, you know, we need to make estrogen, we metabolize or break down estrogen, and then we need to clear it. It's like this 3-step dance, and then wash and repeat. And you could have a problem anywhere in that step. And then the adrenal hormones are nice. Now for thyroid, the best test is a blood test, but you want a full blood panel. So Katie, can you post the link for the thyroid adrenal class? For people who want to learn more, that can be a good one. It's not, you know, if you're a new practitioner, you'll probably get benefit from it, but otherwise I do a more in-depth practitioner class. This is just a quick little snapshot of the first view, the first page of the Dutch test. It's multiple pages. But you can see in this patient, they were quite low in estrogen. And you can see from their daily free cortisol pattern was off. There's sort of a little bit of a precipitous drop in the afternoon. They had low energy, and then really creeping up too high at night. That's going to interfere with sleep. Anyway, I'm not going to get into all of it, but important things to note. Here's another cortisol pattern. This is on the Dutch test, so it's included. And I'm not showing you all the pages. There's a lot of pages to it. For thyroid, I cover thyroid in that other class, so go there to see it. But what I just want to say is, you know, we don't jump into a disease state. So our endocrinologists are not going to diagnose hypo or hyperthyroidism until you fall off this bell curve. And they mostly use TSH, thyroid stimulating hormone. Well, TSH is produced in the brain, the anterior pituitary gland. It signals the thyroid. It still does not measure what's being produced at the thyroid, and not every person metabolizes TSH the same way. So it's sort of asinine to not order more. So I like to see TSH, T4, T3, both thyroid antibodies. There's other thyroid markers that could be helpful, but those are sort of what I like to see at a minimum. And then some patients, you know, they're not going to get diagnosed with a high TSH, a hypothyroidism situation until they're 4.5 or above, but maybe there are 3. So like the functional range is 1 to 2. You know, you sort of march over there. You don't leap into a disease state. And I would rather see, can we make a change, use some natural tools and get people feeling better before we wait for them to get into a disease. Jesse, I see that question. I'm happy to answer it. I absolutely will. The short version, just so you know, I'll say real quick, Functional Medicine Academy and IFM. IFM's brilliant. I love it. I went through all the training. It's involved. It's a big process. There's a reason only 1,500 practitioners are fully certified. It's a really intense, you know, case review and testing process, and it's pricey, it takes time, but it's an excellent education. I was already training physicians. I wouldn't have created Functional Medicine Academy except I saw really qualified people closing their practices and not succeeding. So Functional Medicine Academy, first of all, it costs a lot less. You can move through it faster. It is very practical. It's focused on what you need to do, like to put into practice on Monday. So it takes that big body of knowledge and just gets into the nitty gritty. One of the courses is all about marketing. One is about like the initial like intake, report of findings, practice setup. The rest are clinical. There is a certification program. You don't have to do it, you can. It's helpful, it's not as intense, but it's really practical knowledge to be able to dive in and use it. So anyway, I can answer more questions, but that's a short version. Okay, dysbiosis, like I said, we've got detailed handouts, but my favorite test, I've used them all, and patients will send them all in, but my favorite one is GI map. So I like that one best. And a lot of key information you want to see. I just gave you a few, like H. pylori is linked to SIBO quite a bit, increased risk with an H. pylori overgrowth. You can see some opportunistic bacteria that will get overgrown when SIBO is present. You'll see methane production. You don't know if it's moved in the small intestines, but you can certainly see an overgrowth in the large intestines. Inflammation. There's bacteria related to weight gain, leaky gut. There's autoimmune strains that we know from research, like Citrobacter and Klebsiella, Prevotella, Proteus, things that we know can initiate and sustain an autoimmune process. Beta-glucuronidase is very helpful, and this is where a wise practitioner is looking at more than one test. If beta-glucuronidase, let me just show it. Oh, I don't have that screen. It's on page 4 of the test. Beta-glucuronidase is an enzyme made by some of these bacteria that overgrow, and when it gets elevated, not only does it perpetuate that dysbiotic state, but it interferes with phase 2 detoxification in the liver, particularly clearance in, I'm going to see if I can turn off this video here real quick. Particularly clearing estrogen. So like if you have a Dutch and a GI map, like maybe you have someone with SIBO, but they have hormone issues too, and they're thinking of doing hormone replacement therapy, but their beta-glucuronidase is very elevated. On their Dutch, you can see that their phase 1, phase 2 metabolism for estrogen is messed up. And then you add a genetic testing and they're, you know, homozygous for COMT. Not a good candidate for hormone replacement therapy, right? This is why patients, you see a functional medicine practitioner. They should put all this together. Also, immune health, SIG-A, right? Your primary immunoglobulin and your mucous membranes, your first line of defense, nose, throat, lungs, gut. If that's particularly low, that's a problem. If it's elevated, you know, it's actively launching a campaign against something. What's going on? There's a little screenshot. You can see Methanobacteriaceae, see in the middle there, 4.20 E8. So not a flag, but certainly higher, right? So the top half is an opportunistic bacteria overgrowth. Bacillus is in soil, so it could be this patient's dysbiotic and they're just prone to an overgrowth, or it could be that they were taking a soil-based probiotic that was high in bacillus. And then the bottom half is still opportunistic bacteria, but the lab separates it into a different section because those are known autoimmune triggers and sustainers. And I don't like it when I see Klebsiella like that high, especially if we know they have leaky gut. All right, I gave you just a little bit of a handout or a little bit of a slide on leaky gut and some of the conditions. You know, the gut is supposed to be somewhat leaky, right? Think of it like a fence, but it's supposed to let across properly digested food and nutrients. When it gets too leaky, the barriers get damaged. Many different ways this can happen. Things can get across. It can be perceived as a foreign invader for the body. And some of the best of what we know with autoimmune conditions at this point is this sort of three-step process of a genetic predisposing factor, step 1, a environmental trigger, step 2, and leaky gut, step 3. I gave more notes on leaky gut. I'm going to pass them just because we're at the end and we need to get to the Q&A, but you can see some of those in that 4th class I shared. So this talk, there's some, if you want to take a screenshot real quick, there's some of the goals for leaky gut repair, some supportive nutrients. This is my favorite test for leaky gut. This is Precision Point Labs. It's a blood test. And I like it because it's not just zonulin. Zonulin can be helpful, but sometimes it's a weak marker for leaky gut. But I like to see if the DAO is low, if histamine's high, what's going on with lipopolysaccharides, right? Endotoxins by bacteria. And there's clinical significance if it's high or low. They also have great lab notes to share with the patient. Okay, preventing relapse. We're right at the tail end here. Sorry, like I said, big class, lots to do. These are my best tips to avoid relapse. Number 1, strong digestive aid. Digestymes is my bias. Katie, if you can type that in. 2, Prokinetic to stimulate the MMC wave. I typically use Modal Pro and Prokine. Number 3, meal spacing, 4 to 5 hours between. You might be done. Those 3 itself might prevent it. 4, if constipation is there, resolve it. Plus any other slow motility issues, like some of the hormonal issues. Number 5, consider LDN if needed. Sometimes that's the missing piece. Siobhan talks about that. It was life-changing for her. It is, the gut community likes it because it is a prokinetic, a weaker one, but for people who have other reasons to use LDN, it makes sense, particularly these autoimmune and pain companies, pain issues. Precision Point Labs is the company that has the leaky gut test that I like the best. And then the stress. Don't forget the stress and belly breathing, visceral massage, right? The structural issues, movement. Okay, so all of that was walking us through this, all right? I made that, so that hasn't been seen before, but I just wanted to summarize what I consider a very complete SIBO Care protocol. Very briefly, what is the patient's experience with SIBO? Bloating, they might have low back pain. They might feel like getting rid of SIBO is the focus and not recognize what other life changes you need to deal with and what you have to do to avoid relapse. We talked about the food issues. They might be doing endless searches with SIBO and Google and Facebook and YouTube, and that can get frustrating. You want to get educated, but you know, it's a lot of work to be really educated in this. And so if you're just a regular person and you hear, well, wait, this one says eat low FODMAP and this one says eat high FODMAP and this one says eat vegan, what do I do? You know, that's what a qualified practitioner is for. Sometimes they want a quick fix and they get frustrated at understanding like the interwoven health issues. Paying out of pocket can be a pain. You know, we can give super bills, but our office is a cash office. So we just try to keep the price as low as possible for patients and do as much free education as possible. Or they're not getting support from their medical community. Family doesn't understand, or they don't want to be different. What is the practitioner experience? Patient compliance can be an issue. Some practitioners feel like they're chasing bacteria, dealing with additional infections and co-occurring infections, getting to the root cause, dealing with the cost of care, troubleshooting other problems, knowing when to order additional tests. Yes, I'll talk more about LDN. We'll go through it. Knowing when to give referrals. And when to make the call. Like, when is it you can't resolve it and we need to deal with the fact that it's a maintenance situation. All right, we're right at the end here. Why would a patient not get better? 1, insufficient testing. I really like pre and post testing. An inaccurate diagnosis, missing other conditions. They didn't do the protocol long enough. That's why you test. They didn't identify the root causes and address them. They didn't vary the protocol. They just kept hitting it with the same thing. They didn't vary the herbal antimicrobials. They didn't understand when a biofilm buster or a binder was needed. They didn't use a prokinetic or understand the MMC wave. They didn't use probiotics when needed. You know, they may put it in too early or not put it in at all. Or they didn't understand the right time of day to use it, or they didn't address dysbiosis. They don't understand the role of stress, vagal tone, lifestyle. Maybe they didn't want to face the fact that they have complicating issues. Maybe they're not a simple case. Maybe, you know, they're like me, they've got a primary immunodeficiency. Maybe they showed up with an autoimmune condition. Maybe they have scars that can't be resolved. Maybe they just didn't want to live a mindful life, or they felt family pressure or financial strain. Maybe they forgot to deal with the upper digestion. So this is a like checklist. If you're not getting better, whether you're the patient or you're the practitioner working with tough cases, this is your checklist. Okay, for those that are interested, I told you we do a free 15-minute consult. Katie, if you can put that link there. I'm going to skip over these quickly, but this is sort of like my chart and grid on restoring health and how to start on the inside and move your way out. You'll see this in other videos we have, so you do have access to it. This sort of just talks about functional medicine, what's involved. And again, this is a graphic we've used in other slides so you can see it. This talks about some of the labs you use and how do you test for certain, you know, when are certain tests appropriate for certain conditions. And that detailed list is here. And you can snag this yourself. Let me give you this link. I don't think I had given it to Katie, but this is a free gift you can grab yourself. It's called 15 Darn Things Keeping You Fat or Sick. It lists those 15 things. You can see it right there, but it's a multi-page PDF and it goes through each of them in detail. And at the end, like let's say 3 of them are an issue for you. At the end, it tells you what kind of tests you would need for that thing. So you're welcome to snag that. And oops, I think I sent that to just one person. Let me send it to everyone. Okay, so it's the 15 darn things. All right, so now I want to know what questions are on your mind. I want you to think about those. Katie's going to unmute herself and start feeding questions to me. And then just remember next week, I think it's Thursday is the 8th, and it's 4 p.m. Pacific Standard Time and 7 p.m. Eastern Standard Time. I'll be on with Siobhan. We'll be talking about her book and talking about SIBO. It's in our Facebook group. So can you give that link, Katie, to our Facebook group? Because that's the only place it's going to show up. So I just want to make sure you're in there. And that's going to be fun. I love doing live Q&A. So with that in mind, let's start doing our live Q&A.
Okay, can you hear me okay?
I can.
So one person was asking, they completed an elemental diet for 3 weeks along with herbal antimicrobials. The SIBO came back with a vengeance despite staying on a prescription Prokinetics. Basically, how can they treat a chronic relapse? They also mentioned hypothyroid and Hashimoto's, and they do take a natural desiccated thyroid.
Okay, so sometimes I will use certain supplements while someone's on an elemental diet. Otherwise, a lot of times I try to just use the elemental diet. The supplements I do use most often would be an antifungal in a low dose. Anyway, sometimes you need more, but otherwise you're trying to do as little as possible, because sometimes you can get ingredients in a supplement that's going to feed the bacteria and make the elemental not as powerful. And when you say it came back, that's implying it was cleared for a bit. So then we have to look at what happened in the lifestyle, what changed. And if it's mostly the thyroid, then working to resolve the thyroid issue more, and make sure motility works. And that, remember this slide right here? you know, if you work with our office, we're doing it. But if you're working with another practitioner, share this with them and see where was something missing, what issue is not being addressed, so you can make sure you go through that and get back to it. But yeah, you need enough thyroid support that you're not maintaining a slow motility issue. So without knowing your exact history, my guess would be that there was just one key issue or more with slow motility, and that was the big part of the regrowth. You might also need to stay on herbal antimicrobials for a longer time coming off of the elemental diet until things normalize, and then wean off of them. And Katie, you can post the questions too if you want, or say them, whatever's easiest. I know it was making sort of a weird sound.
Okay, yeah, I'll mute myself between questions. The next comment is someone that said they were experiencing palpitations after meals. Is that a SIBO symptom?
It's not necessarily a SIBO symptom, but it's not uncommon when people have an upper digestive issue. It could be a histamine issue. So I have some patients with histamine intolerance and mast cell activation syndrome, and they can sometimes experience that. So there can be, you know, low stomach acid, histamine activation in response to food. Some people do it because of a food allergy. My favorite allergy test, by the way, a lot of food allergies, you know, testing sort of sucks. My favorite one is also by Precision Point Labs, and I like it because it tests for true allergies, IgE. It will test for immune tolerance and blocking potential with IgG4. It will test for IgG, which is what most food testing is, and it will test for C3D, which is complement, all in one test. That's what I want to see. Otherwise, I think it's a waste of money. So some people are eating a food they're actually allergic to. Some people are in such a heightened allergenic state, they're having it just to food itself. So then we have to deal with the acids produced when you eat. Other people can have that response and palpitation in response to the stomach stretching, and they may have some vagus nerve issues. So then we have to resolve the vagus nerve. So the vagus nerve, besides its role in gut-brain communication and, you know, calming the body down. I mean, it does so many different things, but it also has to do with your heart and your heart rate and heartbeat. And so a little trick, by the way, would be to use pharma-GABA. If you could type that in, Katie. I love pharma-GABA. And if that happens, see if pharma-GABA helps change those palpitations. That could be very helpful. In fact, it's one of the few things I keep right here at my desk. See, love it. And this is a nice, clean, safe dose. You chew it, and it's a low dose, so you can take more if needed. Okay, one question I see, I know you're gonna ask me a question, Katie, but I just saw it, so I'm gonna answer it. What to do if SIG-A is low? That was the slide I showed you that had the immune support on it. And what I typically use is Tegracell colostrum from Designs for Health, or Mega IgG 2000 from Microbiome Labs, or SBI Protect from Orthomolecular, which is in a powder or capsule version. Floromyces, which is Saccharomyces boulardii, can also help increase SIG-A. All right, do we have another question?
We have several questions. Do you know the lab for the IBS blood test, that anti-ciculin and anti-CBTV antibody?
IBS Smart. So there's only one. It's Gemelli or something like that. So if you just Google IBS Smart, you can see it. And like I said, we order it for patients, but I think you can actually order it yourself online. So, and sometimes you can submit a statement into insurance and have them cover it. So it's good information to have.
Do we have a link to the MTHFR or genomics homocysteine class? Someone was asking.
That is the link to Functional Medicine Academy. I talk about it in there. And the next time those classes are going to start are probably this summer. And you can just take the class that interests you, or you could take the whole certification. So, and I'm assuming this is a practitioner, because these are practitioner classes. So for practitioners who want to know what's going on, if you want to just get on our email list, you might already be on it, but if not, email team@bodylovecafe.com and just say, please add me to the practitioner list. Just include your name and email, and I'll make sure you know when the classes are. That's also, that practitioner list will also be when I release, I don't know if you know, I created a lab analysis software tool, and SIBO testing's included. The first one I built was just for blood labs, and our clinic has used it for over 4 years. And the new one, practitioners all around the world can use it. It's all functional and medical ranges, and it has 130 blood markers. It has SIBO breath testing. It has organic acid tests, urine metabolites. It has Dutch. It has GI map. It has leaky gut, and it has urinalysis. So all of that's on there. Very low cost. Your staff member could just type it in, spits out a PDF for you and for patients, says what it means, lifestyle changes, and helpful supplements. So I'll announce that to that. All right, have another question.
Someone was asking, does water have any effect on bacteria blooms?
Like just drinking regular water? Well, it could if there was a waterborne bacteria. But otherwise, if you're getting regular water, the only issue I see is I encourage people not to drink a lot of water with their meals, because I don't want to dilute digestive juices. I try to encourage people to have a fair amount of water in between their meals. But other than that, unless it was carrying a bacteria that could infect you, it's not really a worry.
Does betaine hydrochloride feed methane?
No, but betaine hydrochloride can be an issue with hydrogen sulfide. What is definitely an issue with hydrogen sulfide is ox bile, and other like NAC, N-acetylcysteine, and glutathione, you know, some of these sulfur producing or sulfur-based supplements is an issue with hydrogen sulfide. Otherwise, I don't see any problems with it with methane.
If scar tissue is one of the causes, adhesions after major surgery, what can be done?
You know, if it's something like that example I gave of endometriosis, where it is really grown through everything, then that person has to have surgery again to go in and remove it all. It's just going to be required because it's so invasive, and then unfortunately you're going to have scars from that, but that may be their best chance. Otherwise, a lot of times you don't want more surgery, right? So a good body worker, and you need someone who knows their anatomy, right? You want a good body worker, like David in our office, for those who are local, does it, but otherwise he's brilliant with scars. But otherwise, find someone close to you. They can do a lot. You know, will they completely break up and make the scar go away? Unlikely. But what they can do is sometimes the scar, there's just a bigger keloid, and there may have been inflammation over time that if it wasn't cleared, it becomes like a gluey substance. And now you start seeing that in between muscles and fascia and connective tissue. And so a good body worker can break that up and help increase the mobility. But getting rid of a scar entirely might be out of luck there. So then you just sort of have to balance it, which how much normal function can return or is it severe enough it becomes a surgical candidate?
A couple other people just commented about this. Will scar tissue cleanup and surgery eradicate SIBO? How do you have GI structural issues assessed or confirmed?
Okay, so will scar tissue eradicate SIBO? If that's the main cause of it, then you'll still have to kill off the SIBO, but you potentially could have gotten rid of something that was making it relapse. Keep in mind, though, that the surgery to get rid of the scar tissue is going to create a scar. So then you want to make sure, as soon as you get the thumbs up from your surgeon, that you get right in with that body worker to make sure the new scar heals properly and you have tissue mobility, right? And you know, GI structural issues, it's a tough one because if you're going to get a colonoscopy, I love like a good functional GI doctor. They're wonderful and sometimes they're hard to come by. So if you talk to like your regular GI, they're only taking biopsy, you know, they're looking for polyps, they're looking for cancer, they're taking biopsies for ulcerative colitis and Crohn's, and they're looking for celiac disease, and that's sort of it. They're not, you know, they might notice a redundant colon or some inflammation, but they're not thinking like, oh, this is a tunnel, and this person complains that every time they eat, sort of like around the left side of their abdomen, that it feels like it gets blocked, and you know, they're just not thinking like that. So if you have a good relationship with them and you can talk to them about it and say, please, can you see what's going on? This is what I have. Brilliant. Sometimes it just won't show, and you're not going to see it in a colonoscopy because it might not even be in the colon. That what feels like a kink or a hairpin turn could be some connective tissue or like a round ligament, you know, like maybe there's a birth injury or something that is torqued. So a good pelvic floor therapist who's going to have advanced training, we refer to Dr. Romy Havard locally. She's brilliant. They can do internal exams. And, you know, so sometimes you can't get to an issue. Some might do an MRI. Otherwise, you just need a good functional medicine doctor who's going to put the story together for you and understands. Like I have some patients, they eat something they ate another time, they think it's fine, they're in terrible pain, they're lying on the floor, drenched in sweat, and unless someone's gone through it, they don't know what that's like and what to do. We have, so we know what to do. But, you know, like I said, you might just need more than one person. But how can you get it assessed or confirmed? Maybe colonoscopy, maybe CT scan, rarely ultrasound, pelvic floor therapist, possibly. Otherwise, good functional medicine practitioner who's willing to ask detailed questions.
With the knowledge that each body is unique, how many months on average for these protocols? How long on a digestive enzyme and other gut healing supplements?
Good questions. Let me just talk about yeast first, because that takes the longest. The fastest I've ever seen yeast truly eradicated with pre and post testing, Candida, is 5 months. Fastest I've ever seen. Some people have it years and never really address it, because what's very common is people get frustrated, and so they feel awful, they do some protocols, they feel better, and then they're like, I'm done, and then they go back to the same stuff and it comes. So it's like this, they never truly get rid of it, right? So to truly get rid of yeast is somewhere between 5 months to 2 years. Just being honest, that's the longest. For SIBO, the fastest is 2 weeks. I've never seen it faster than 2 weeks. The longest would be someone who doesn't resolve and they have to maintain and live with it, and we have to make a good quality of life. Otherwise, quite often, you know, a couple months, you can get rid of it. And then the really stubborn cases might be 6 to 12 months. And then at that point, if you've dealt with every other root cause and layer, you might be, you know, calling it that this is an ongoing management issue. And then the digestive aid, quite frankly, Digestimes is probably the thing you would be on the longest. You know, I just stay on it. The benefit far outweighs the cost, because there's just so many things that if you can have good, proper digestion in that upper level, the benefits are endless. A Prokinetic, some SIBO patients are on it for life. I would say my SIBO patients on average are on it probably 3 to 6 months. So not necessarily long-term, but some people are going to be on it long-term.
Do you think fructose malabsorption breath test is an accurate method of measuring SIBO?
No, I don't. I think it's an accurate test for fructose malabsorption, but not for SIBO.
What if you have Epstein-Barr virus?
Well, so Epstein-Barr virus, you know, 95, 98% of adults have been exposed to it. So you can test positive that you've had it in the past. We give our patients, we do order that test. We give our patients a handout to know when it's reactivated or not, because that can certainly play a role. When I got really sick and I went back to school, I actually had renewed my license just so I could order the test myself. And my levels were over 600. It was completely reactivated. Some people don't know that a really like good yeast infection, like a systemic yeast Candida infection, can reactivate an old Epstein-Barr virus infection. You have to like read all of PubMed to get to that, which I think I did. And it can take some time to resolve, but Epstein-Barr virus should resolve. You should get to where you don't have a reactivated case and it's not active. So you have to deal with it. But viruses, I mean, certainly that's on everyone's mind right now. Viruses are very clever and creative. People argue, are they living or not, because they have to have a host. I tend to lean towards, I think they're living because yes, they require a host, but they have some unique properties. The way they can mutate and translate and work together and lay in wait, lay dormant and reactivate. I mean, quite dynamic. So we've had, you know, new acute Epstein-Barr virus cases, reactivated cases. The most stubborn one I had took 7 months to resolve before it would test clear. And that was a new acute one.
A person commented they have overactive bowels tending towards IBS diarrhea. Would a Prokinetic still be helpful? Basically needs less help keeping things moving.
Yeah, so you want to time that if even needed at all. What I would want to know is if it's just IBS diarrhea, we have things to do for that, right? Is it SIBO? If it's SIBO, then we need to figure that out. But while they're having loose stools, I wouldn't be putting a Prokinetic in until I knew for sure there was slow motility from the stomach to the small intestines. Remember, a Prokinetic is not a laxative. So yes, it's the same long tunnel, but it's a little bit of different mechanisms here. And I would certainly be wanting to deal with the problem right in front of me. Floromyces or Saccharomyces boulardii, by the way, is one of the first things people reach for loose stools and traveler's diarrhea. But if they have ongoing loose stools, probably the best place to start is with that IBS Smart or IBS Sure test to you know, see if they have post-infectious IBS. And then depending on the results there, maybe go to a SIBO test from there. So you don't have to get every test all at once. You might not need them all, right? So you might get one and then the next as indicated.
Someone said they had a lactulose reading that was off. Does that mean that their baseline is off? Is that common?
That it was off? Well, lactulose is the substrate we use for breath testing because it's not absorbed by humans. So it's a good one to track all the way through the intestines. That's why we like it. If it was off, I'm trying to understand what off is. If it was a high baseline, it could be that the test prep was not done correctly. If it's a high baseline of methane, that doesn't always mean that the test prep is off, because methane, you know, like we said, is good at moving on its own. But yeah, if hydrogen was high at baseline, that's often a sign that the test prep wasn't done correctly.
Could chiropractic have set off an acute chain of events, open an ileocecal valve possibly, caused nerve damage, symptom onset directly after aggressive adjustments?
If it's an adjustment like adjusting the low back or the pelvis, it's unlikely. If it was a visceral adjustment going after the ileocecal valve, which chiropractors and osteopaths and some PTs and body workers do, it's possible that if they, this is in theory, I don't have any evidence to demonstrate it, but it's possible that if they, you know, open the ileocecal valve and it, you know, wasn't able to close properly, that created sort of an open door, you know, situation for bacteria to go from the large intestines to the small intestines. Same thing with a colonoscopy. I mean, you rinse everything out before a colonoscopy, but most GI docs are trying to get the scope all the way up into that tail end of the ileum there. And they're looking at the ileocecal valve. So it's certainly possible to have a damaged ileocecal valve, but it's not really common. So I don't want to say it's not possible, but it's not the most common scenario. Most people who get that visceral maneuver of ileocecal valve or a functional hiatal hernia, we describe it as sort of like a front door and back door to the small intestines, and it helps like create some motility, but it's usually a temporary thing. You know, you're not really getting in and touching the ileocecal valve. You're using tissue of the body to try to pull it a bit. So for most people, it's harder to even do it right than to get into a situation where you do it wrong, but it's possible, right? I guess anything is possible in that situation. But yeah, what most people, I would say, notice is they weren't able to go to the bathroom and then all of a sudden they are. But actual nerve damage, usually that's like a car accident of some sort, you know, really high force. It's very hard for a human being to create that much force.
Why do you recommend the high FODMAP during the kill phase?
You know, it's something Dr. Mark Pimentel would recommend, and we use it particularly with the SIBO dominant, the methane dominant. The theory behind it was that well-fed bacteria were easier to kill. So that's the recommendation. You don't have to do it. And if you are going to do it, it does not mean ice cream sundaes. It just means higher FODMAP. Again, when you're doing antibiotics, that is the strongest kill agent, right? It is a bit of a gut bomb. So there's pros and cons to going that route. I saw a question too, how do you treat hydrogen sulfide dominant SIBO? Research is still learning more about it. Like I said, that's the newcomer. But rifaximin, the antibiotic, is the most common prescription agent. And then adding bismuth, even just Pepto-Bismol 3 times a day. Functionally, we often use molybdenum. Molybdenum has some clinical and research evidence showing it will reduce SRB, sulfate reducing bacteria, so reduce some of the sulfate production. We avoid biophilic products and sulfur-based products, so we avoid ox bile salt. So this would be an example where you wouldn't use digeszymes. I would maybe give betaine hydrochloride separately and some pancreatic enzymes. But with hydrogen sulfide, you wouldn't use ox bile, and you wouldn't use NAC and glutathione, and you would trial a low sulfur or vegan diet. So a very different protocol.
I think you touched on biocidin earlier. Someone was asking your thoughts on biocidin.
I like biocidin. I think by itself, it's not enough. But as one of the tools in the toolbox, I think it's very helpful. We use it a lot, and we've used it for years. They have a good toothpaste too. You know, a trick for the mouth stuff, by the way, is Designs for Health. If you can type this in, Katie, they have a peribiotic toothpaste that's excellent. You know, the mouth is part of the microbiome. And especially when I see certain bacteria overgrowth in a stool test that's more commonly in the mouth, I recommend peribiotic. I use it myself. I love that toothpaste. There's you know, you can do tongue scraping. Sometimes you can rinse with grapefruit seed extract if you get, you know, a fungus overgrowth, but just keep in mind, you don't really want to have grapefruit seed extract hanging out by your teeth because it's so powerful. It could be a little corrosive, but very short-term use, you'd be fine. You can buy charcoal. You don't have to get the fancy charcoal toothpaste, but you just get charcoal. One little container will probably last the rest of your life. And, you know, make sure it's food grade, but you put that on your toothbrush and do that 1 or 2 times a week when you first have it. And for maintenance, you may only do it once or twice a month, but that's a very low cost, inexpensive way. It binds with the bacteria. Your teeth will look so bright. You'll feel like Halloween because you'll be brushing for 2 minutes. Your mouth's all black, but that's a good trick. So anyway, couple little things there. What else?
That's perfect. You just answered the next question about would you do the thrush with the elemental diet. Those oral recommendations.
Good.
Another person said they've been dealing with SIBO for 7 years and they're managing it well. Should she continue to work with a doc to manage? She hasn't seen her GI doc in 3 years, but did want some advice to manage better.
You know, I would grab that slide about, you know, why do people not get better? And I'd grab the slide on the root causes. And I would just look at it yourself and see, is there anything here we haven't addressed? And, you know, if there is, go back to your practitioner and talk to them and just say, you know, we're managing things well, but you know, I want to see, we haven't really looked at this area. I want to see if we can do some work on it. And is it possible we can get rid of it, or, you know, just take the healing to the next level? And if you haven't done the Trio Smart test, because that's relatively new, you might want to consider doing that and see where your levels are at.
What do you think of Dr. Nye's low/no sulfur protocol? They found it extremely helpful in eliminating hydrogen sulfur.
I haven't read their protocol exactly, so I can't comment, but we use a low sulfur diet. So I'm sure it's very similar. Again, you still want to get rid of it, right? So those are helpful tools, but it won't solve it itself. So use the helpful tool, the low sulfur diet. But ideally, you don't want to keep hydrogen sulfide and not be able to have sulfur, because sulfur is actually a key ingredient and part of good health, right? Just like fiber. You know, we use a lower fiber and fermentable food with a lot of SIBO cases, but ideally you don't want to have a life where you can't have fiber and you can't have fermentable foods. So, so that's the goal, is to always, as much as possible, get back to normal eating where we don't have to cut out a bunch of foods. I realize some people that's not an option, but yeah, I was thinking of a case where I had to use a low sulfur vegan diet with a patient for a couple months, and then they were able to reintroduce, you know, animal protein again. So hopefully short-term use, and good that it's helping. Makes sense. It helps to confirm that hydrogen sulfide is likely the culprit if that diet is giving relief.
Does there exist any objective testing to determine if there is a biofilm?
That's a good question. I don't know. Can you write that down for me, Katie? I'll do a little bit more research and see if I can come up with an answer. There's a few like sort of esoteric tests I'm thinking of that, quite frankly, I don't think are worth spending the money on right now. I don't know if there's something really good that can confirm that. I just think the best example, and I'll look and see if I can find something else, but I just think the best example is someone where you have confirmed there's a bacterial overgrowth or yeast overgrowth. You know there's something in the gut that needs to be worked on. You start to address it, and people are like, I notice nothing, you know, or you retest and there's zero change. And then you introduce a biofilm and now you start getting shifts. So in some cases, you know, that's where clinical wisdom comes in. But if I can find something that's a good test, I'll let you know.
Someone asked if they can eat natto rather than take the pill.
You know, you can't quite eat enough to equate to the supplement level, and there's other ingredients besides natto. But natto is an excellent source of vitamin K2. So if you like natto, by all means, eat it. And you don't have to take natto Cerezyme unless you need a biofilm agent and or you want something that's, you know, pro-thrombolytic. Like how some people take an aspirin a day. This is like a natural version of doing that. So when I see like LP play 2, you know, lipoprotein associated phospholipase A2 quite elevated, which is an enzyme that's a sign of soft, active, unstable growing plaque in the arteries, I would reach for nattocerezyme.
When do you give a biofilm buster on an empty stomach with food, and do you do it during antibiotics?
Ideally on an empty stomach. And really watch how you feel, or doctors watch how your patients feel, because I always tell them, you know, you're usually bringing that out for someone who notices nothing. So I always tell them, if something's going to make you feel crappy, it's going to be that biofilm buster, right? Because all of a sudden now it's going to break down biofilms. You're going to get a flood of this bacteria or yeast into the body. And if they have leaky gut, potentially into the bloodstream. So that's why I always like the patient to be really, really empowered to be in control of that. But yes, ideally on an empty stomach. And would you take it with antibiotics? That's an interesting question. You know, typically you don't, but if you were doing like that rifaximin, flagyl, or neomycin protocol, you could. It's such a strong kill agent. I think you're going to notice something from the start, but you know, it's a 2-week protocol. If you were at day 4 or 5 in and you notice nothing, then adding a biofilm buster would be a good thought, you know.
Do you recommend coffee enemas for methane SIBO?
You know, coffee enemas are controversial, but some patients do see benefits from them. First of all, it doesn't get in the small intestine, so I don't recommend it for SIBO. If someone had a methane overgrowth in the colon, could it help? I don't know. It's not going to kill the methane. If someone is constipated and it's helping to move a bowel movement, you know, create a bowel movement, then that's helpful, but you're still going to have to kill off and bring the methane back into normal levels. So coffee is not going to do that. The proponents of a coffee enema, we know the benefits of an enema, right? Enemas have been around forever. But the proponents of a coffee enema, we don't really understand why some people get benefits. There's a lot of thoughts about it, and it has to do with detoxification. But I don't know of any evidence that links it to methane particularly.
While we're on the topic, someone asked if there's any evidence base regarding using probiotics as enema instead of oral.
Well, there is, but not necessarily the home cooked version. I always say, don't do this at home. This is definitely a hospital procedure. FMT, fecal microbiota transplant, we have excellent evidence. It's 99% effective for C. diff. It is the best treatment for C. diff. If you even go to John Muir, which is our hospital here, their ER, and you have C. diff, even on their little handheld device, it's going to pull up FMT as the #1 treatment protocol. But what they will tell you, and I know this because I've worked with patients in the ER, the lovely MD will tell you, I don't even know how to order this. And so Medicare in the United States will only cover FMT, even though it's the best treatment, and seniors are certainly more susceptible. And C. diff can have up to a 40% mortality rate. It's no joke, highly contagious. Medicare will only pay for FMT if the senior has gone through 4 failed rounds of antibiotics. So antibiotics most commonly cause C. diff, which is the same reason there's an increased risk after elemental diet. And then they'll use a different strain of antibiotics to treat it. After 4 failed rounds, Medicare will pay for it. So we certainly know, we've learned a lot with FMT. This is part of how we learned about how fat and thin people have certain strains of bacteria in their gut, because someone got an FMT, they'd been thin their whole life, and then they gained 30 pounds like 2 months after it. It was taken from an overweight donor, and the profile, the ecology was different, the bacteria. And our scientists are still studying it all the time, although they've been, pretty much everyone's been on COVID like the last year, right? But we learn more and more about the microbiome all the time, and it's absolutely fascinating. Do we have a pill yet that you can like just randomly take and repopulate the right strain to lose weight or whatever? No, it's probably coming. And some people, if fecal microbiota transplants are mostly done through the colon, but now there is a capsule. For someone with SIBO, I'd be very worried about that. What if it opened up in the small intestines? But there are capsules now. But it's a hospital procedure because, and I have patients, I didn't tell them to do this, they came this way, but they've done it themselves at home. But, you know, a hospital is going to, you know, check for infections, remove everything except for the beneficial bacteria, check for viruses. They're going to check the strains. Now they check for donors, you know, because what we've learned. And I really do think this bacteria is the medicine of the future, but I don't know, are we a decade or 2 decades away from it? Some people pay right now to go to, like, I don't know if it's in the Virgin Islands, there's a place in England. There's some places where they pay and go to get a fecal microbiota transplant. And for some, it's sort of a life-changing difference, and some are disappointed. You know, we're still learning about it. And it's not a treatment for SIBO per se, but for people who have a methane overgrowth or a dysbiosis, it can be very helpful, but it's not readily available.
What is the usual time frame for using probiotics? When do you introduce probiotics after a person completes elemental diet?
Someone who might need probiotics in even separate from SIBO, I might give them a couple, like I told you, my top 3 or 4, and I'll have them rotated, and they might be on that for life. The best scenario would be they don't need a supplement and they just get it from their food, but not everyone will tolerate it, and not everyone has that you know, access or discipline, you know, to get it in their food. So it just depends. You know, if you're in America, we don't have a very good diet here. So they might just need it. And part of why they need it is because if you look at the 5R approach, it says repopulate, but it doesn't really repopulate. It just moves through, everything sort of works better while it's in there, and then it's gone. And unfortunately, some people have completely lost strains. And when you're looking at, let's say, like GI map, the commensal bacteria, and you see like Akkermansia is completely gone, that's a problem. It's hard for someone to get completely healthy if that's entirely gone, and you don't know if it's going to regrow or not. So sometimes strains are gone, and it could have been antibiotics that completely wiped it out, or it could be, you know, you initially get your gut bacteria from a vaginal birth with mom. It could be mom didn't have it, right? Or it wasn't in the environment afterwards. That's the second way you get it. So yeah, some people are going to be on them indefinitely. Other people, they just use them here and there as needed. And for SIBO, a lot of times, a lot of docs will reach for those soil-based probiotics first because they're better tolerated. Some don't like to use them at all. You know, ProBiomed, I like it. It's not spore-based. It's not a soil-based. ProBiomed has the top 10 strains that we know are beneficial for the colon, and I've found it really well tolerated by my SIBO patients, and I've tried so many, and so that's why I like that one. And I just feel like people have better poops, you know. I want them to not be constipated. It's a tiny little capsule. They just seem to do better with it. But honestly, everyone's different. So I can't give you a standard with that. I have had some SIBO patients where I gave them a probiotic, you know, day one. I would say more commonly, I don't bring it in for a month or two, but every case is different.
For a SIBO patient with MTHFR, say double homozygous, what added considerations would you say are beneficial to add to prevent a Herxheimer effect?
So with MTHFR, the biggest issue is the impact on the folate cycle and feeding into the methylation cycle. And then just that whole train of one carbon metabolism, right? All the way down through transsulfuration. So a good B vitamin, and the easiest ones, this is another Designs for Health, this is part of why I like them, is they'll use 5-MTHF for their folate and methylcobalamin for their B12. So B Supreme is often sufficient, just one a day, easy peasy. And that's usually plenty. For people who have elevated homocysteine, there's one called Homocysteine Supreme that might be indicated, but the B Supreme has all of your Bs, and Bs are water soluble vitamins. You're going to like blow through them in a day. You just take one a day. It's easy. Otherwise, you know, if there's other detoxification issues, because the B vitamins are the biggest issue, but if there's other detoxification issues, you might need to give liver support. So you sort of watch, don't assume everyone needs everything, because then they need a suitcase for their supplements. But if they have a really strong reaction, like it's too hard, and it's not just, oh, they started to do this SIBO protocol and they switched from constipation to loose stools, but it's also like they just feel like crap. Or they feel like, let's say they feel crazy fatigued. They might be mobilizing metals. One of the biggest signs you have that someone's mobilizing metals is they're just exhausted. Those of you that do energy testing techniques, it's like they can't hold their arm up anymore. You can't muscle test. They're just wiped. So then you got to deal with metals. But anyway, if you give something, it's really, really hard and they feel really crummy. First of all, you can always pause it or half the dose, but otherwise they might need some liver support. So you might want, you know, some milk thistle or a liver cleanse. You might want to educate them on eating less sugars, avoiding fructose, no agave. That's like toxic to the liver and will cause fatty deposits quite quick. Hepatotone Plus is a good product for that. Sometimes we need more aggressive detox, but I don't like to assume the worst, right? We just deal with it as it comes up. So yeah, MTHFR, B Supreme should be enough to start with. If they're really a low methyl eater, then using like a universal methyl donor such as SAMe would be indicated. And usually one a day is sufficient. Really good psychiatrists will utilize SAMe before they prescribe for depression and anxiety. Not that it's specific for that, but it impacts every cell in the body, and a lot of times improving methylation can greatly improve those conditions. I saw a question and it came just to me, so let me answer it real quick. Is probiophage better than ProBiomed. They're different. They're just different. ProBiomed is the top 10 key beneficial strains of a probiotic. ProbioPhage has 4 phages in it, viruses that will kill opportunistic bacteria, particularly in the E. coli family. You use them differently, and sometimes you'll use both at the same time. Another one sent directly to me is what was ProbioMax for? ProbioMax is a Zymogen product, and the reason I mentioned it, it's hard, this was in research, right? These are from PubMed articles, and it's hard to find a product that has it, but it's Bifidobacteria lactis HN019. That strain, HN019, specifically shortens, thank you, Nancy, I appreciate the kind words. Those of you that can leave a Google review, if you can put that link again, Katie, that really helps us out. Thank you so much for it. Even if you just copy and paste, love it. Anyway, that HN019 strain is scientifically proven to shorten transit time throughout the gut. So that's very, very helpful. Let me just see if there's any more directs. Are you supposed to take Prokind on an empty stomach? You know, ideally all Prokinetics, you would take like half an hour after a meal. The problem is most people can't remember that. You know, my sickest patients, you could tell them 11 different times a day to take it. They're going to set a timer. They're going to do it exactly. I'm thinking of like a patient I had, a gentleman with Lyme, who was like, couldn't work the corporate job. It seemed like a skeleton and a ghost of a person, and was not well, and came in, was spending $2,000 a month on supplements and gone through multiple practitioners. And not only we were able to get the Lyme to resolve and get them back to work and get them on like 500 or less in supplements, which is still a lot, but considering he was doing 2,000, this was a huge improvement. But he was able to go back to work, and I remember him distinctly saying, well, I just had the first month where I didn't think about my health. Like that was like huge. That was a big deal, like to be normal and to thrive. And even when he moved, he would still come to our office. You know, sometimes it was like a 4-hour drive. But anyway, I mentioned that because that was an example of someone where they were so sick that you could give very, very specific instructions, and they're going to follow it exactly to get the best benefit. So a Prokinetic best benefit is you take it half an hour after a meal. But for people who are like, I'm not going to remember that, I just tell them to take it at the end of a meal, and that's easier to remember.
Thoughts on magnesium to resolve digestion in terms of SIBO?
Well, it's not going to resolve digestion, but Americans, about almost half, are chronically low in magnesium. So giving magnesium is often a good call. And magnesium, there's many different forms. It can certainly stimulate the bowel. I don't necessarily want it clearing out. If someone's really constipated, I like Colon RX. If you can type that one in, Katie, that has Triphalia and magnesium oxide, but I want them ideally on short-term use. But my SIBO patients know that if when they're in recovery and if they haven't had a bowel movement by 10 a.m., they will take 2 Colon RX. My goal though is that if they have a bottle of Colon RX, it sits on their shelf, and that's the last bottle they ever buy of it, right? They just don't need it regularly. But a formula that I do like for regular use is magnesium buffered chelate. If you could type that in, that's a Designs for Health one. And that is magnesium bisglycinate. It's a good blend. It's better absorbed. You usually don't need as much. You could take 2 at night, and I like to pair that with tributrin. If you could type that in, Katie, or I can do it if you need. But tributrin is a Designs for Health, and it's butyrate, right? So short chain fatty acid. And that's as someone who's dealt with this stuff chronically, that's what I take. I take 2 magnesium buffered chelate, and 1 tributrin each night, and it's great. And I don't have to use colon RX or anything else, you know, normal bowels, which after decades of constipation is so nice to have that normalized.
Perfect. I think you answered that second. My next question, someone was saying they did elemental diet for 2 weeks and they felt great, but then they had constipation issues after reintroducing foods.
To make sure they have a digestive aid and a prokinetic. So you don't want to reintroduce foods without having a digestive aid and a prokinetic. An elemental diet, you know, for patients listening and for practitioners, everyone focuses on elemental diet because that seems like the big deal, but that 2 to 3 weeks goes by really fast. And the bigger deal is the reintroduction of food and moving forward. That's where people need a lot of counsel, right? And might need a higher frequency of visits, or if you have a health coach trained in your office, maybe a lower cost visit that can answer a lot of questions. But how you introduce foods and making sure we don't want constipation at all. It's too much of a risk factor for the SIBO to regrow and to regrow other stuff, you know. Just think about, you know, if you left poop out and it attracts the flies and what happens. Or like, think of fungus, you know, if you have some dirt in the bathroom and you don't clean it off, it's a warm, moist place. It's a great place for mold to start growing. Well, the colon is a dark, warm, moist place. We need stuff moving through it. We don't want it to stagnate. That's when nasties will grow. So anyway, Digestimes and Modal Pro or Prokine for sure. And then coming off of the elemental diet, you usually need an antimicrobial and a possible antifungal at least for a couple weeks, if not a couple months coming off of it. So you got to make sure you continue the progress and do not allow constipation. Natural calm, you can take that, just be sure you watch for the sugar. And if I remember correctly, natural calm is magnesium oxide. So you don't want to use that long term. If you use magnesium oxide too much long term, you're going to become dependent on it and you're going to lose some of your body's natural ability for peristalsis. So you don't want that. Just like you wouldn't want to, senna is very strong. You want to either avoid senna or very short term. So there's a reason why I recommend colon RX, but I hope 1 bottle is all they'll need, right? I don't want people taking magnesium oxide regularly.
I think you were able to talk about this earlier, but someone was talking about a person doing elemental diet for 40 days, and you said that was not recommended.
It's too long. A trick for elemental diet is it's also good for ulcerative colitis and possibly Crohn's, you know, inflammatory bowel disease. But the patients who are using it for that, they're not doing an elemental diet. They're using the formula and they might have it for 1 or 2 meals a day and then they eat a meal. But because of their inflammatory bowel disease, this actually helps keep them, you know, functional. They have less, they're getting nutrients, so they're not starving, but they have less fiber and bulk moving through their gut, and they're having to truly digest 1 meal a day. So they're not starving their large intestines, but they're also not suffering. So that can, or if they have a flare up, right? Because we have some patients with like Crohn's and UC and, you know, been able to avoid flare-ups for years, which is great. But if they have a flare-up, reaching for elemental diet can be helpful in that way. So you're using the formula in a different way, okay? But you don't really want to be on an elemental diet past like 3 weeks because you're going to starve that lower bacteria too much. Remember, there's that risk of C. diff, but even if someone doesn't get C. diff, which is more extreme, you can create dysbiosis. You know, you have to have fiber and you have to feed that beneficial bacteria. You have to make short chain fatty acids. So that's a really important part of health. We don't want to say, oh, SIBO bacteria bad, let's wipe it all out, because that's the whole thing about it. It's like the long tunnel, but a very different environment in each place. And one place we really don't want bacteria, and the other one we really want a lot of bacteria. We just want the beneficial. So unfortunately, This is the blessing and burden of gut health. For those of you that are practitioners, if you really understand this and you work with these patients, you will never not be busy because it's a lot of work and it's really common to have these issues. That's why we talked about IBS and how often that was misunderstood or misdiagnosed. But unfortunately, you can't say like, I'm going to give you this prescription or this natural agent, and I only want it to go to your small intestines and skip your colon or the other way. That's what makes it complicated, right? We can't isolate these things and say, you go to your room and you go to yours.
Also regarding elemental diet, can a patient do elemental diet every 3 months if the issue is recurring?
You could, but why is it reoccurring? Let's get to the bottom of that. What can we do to try to resolve it so it doesn't reoccur? Because even if someone's in a maintenance issue and you know they have something where they can't get rid of it completely, can we manage it so it doesn't end up in an overgrowth situation where you have to keep repeating elemental diet? And if the answer is no, we can't, then yes, you can repeat elemental diet.
Biofilm busters and binders, is there a symptom you look for or some indirect measure to signal that it's time for the patient to stop use and that the job was done?
So let's say you needed a biofilm buster, you're doing a SIBO protocol. So really they're feeling better, bowels are normal, bloating's gone, you do a retest, levels are normal, don't need a biofilm buster anymore, don't need a SIBO protocol anymore. The binder is typically very, very short term. It's usually sort of a crisis situation and it often resolves on its own in a couple days. So, but for some people, again, if they're in that chronic situation, it can help to have the binder on hand, but they're not going to have to use it much. Probably one binder would last them forever. One bottle, you know.
How do sex hormones affect motility?
Well, so thyroid isn't a sex hormone, but thyroid, adrenal, and sex hormones impact one another. They are all signaled by the hypothalamus and pituitary in the brain, and they all have a feedback loop that feeds back up to it. So we sort of refer to it as the endocrine triangle. When one gets off, it can throw the others off. Thyroid, for example, a slow thyroid can cause a sluggish, slow motility. Just like a fast thyroid, a hyperthyroid, besides a fast heartbeat and weight loss, can cause loose stools. Everything can move through too fast. So that could create a malabsorption issue. A high cortisol situation turns off digestion, because if your body's in a panic alarm state and it thinks it has to get away from a tiger, it doesn't care about digestion. And then the actual sex hormones, they're usually more impacted by that. But, you know, both high and low estrogen can contribute to weight gain. And then high estrogen can impact cortisol. It can signal different changes in the liver. The liver has a bidirectional crosstalk. I'm getting too geeked out here, but a bidirectional crosstalk with mitochondria from the gut to the liver. I teach that when I do the missed patient protocol for practitioners. Progesterone, if it's too low, can contribute to anxiety and insomnia. It can throw off cycle signaling. So you have to just sort of follow the pathway through to see how it plays a role. The sex hormones themselves are more likely secondarily signaled. Okay, let's do like 2 more questions just because we went way over.
Oh, 2 more, that's not enough. But let's just see. Some kind of general questions were about if H. pylori shows up on a GI map, do you have to fix that first before SIBO?
You can do both at the same time. One thing I like about GI map is if the H. pylori is overgrown enough, they will test virulence factors, because H. pylori is most well known for causing ulcers and in about 2% of the cases, stomach cancer, right? So I love that GI map test for all those virulence factors, because if they come back positive, that's a bigger issue, right? If they come back negative, I'm less worried. But H. pylori is definitely a risk factor and associated with SIBO. So yes, part of a true SIBO protocol is you deal with H. pylori and digestion at the same time.
When do you recommend repeating the GI map test? How soon after working on issues originally identified?
If someone is really better, then we can skip retesting it, because I'm always very sensitive to people having to pay for tests, right? If they're not all the way better, or they just really had some bad findings that were like a hot mess on the test, then I will retest not earlier than 2 months, more likely 4 to 6 months. And sometimes longer. It just depends on how many things. I have some patients where they come in and they already have a bunch of tests from other practitioners. I have some patients who come in and we only order one test and we're focused on one thing. I have other patients who come in and when I say other practitioners see patients in our office, but we all work as a team, and I supervise all the care and helping to read all the labs. So we're an unusual clinic in that sense, that we have ongoing weekly meetings and training. That's just part of our clinic culture. But I have a lot of practitioners who want to join because of that, actually. They like the ongoing training and the collaboration, someone else's eyes on labs and things like that. But let's see, I was saying something about that test. Sorry, I lost my train of thought because I got distracted. Do you remember what it was, Katie?
No, sorry, I was adding the link for the no charge consult if we're not going to get to all the questions. So people to please schedule, and we will get your questions answered regardless.
Yes, and then also remember we have that interview next week too. So if you had a bunch of questions, Katie, that we missed, we could certainly grab those questions and use that as a kickoff during next Thursday and catch them there. Sound good?
Perfect. I have them all typed up and I will put them into a document for you.
Okay. Oh, and now I remember what I was saying. My train of thought that I lost was sometimes people come in and they just want to like find out everything. And I love it when they'll actually do more tests and budget will allow for it. And they can do like a GI map and a Dutch and a thyroid panel and a leaky gut test. You know, not everyone can do it and not everyone needs it. But for people who really have a lot of issues and you're able to layer those tests together, that is lovely. You get a much more complete picture. But when that's not possible, there's certainly tons you can do with people. Having a clinical dialogue, having a good intake, and even one test can be quite valuable. All right, everyone. Thank you so much. That was a marathon. One topic. That's the way SIBO is, and probably our longest class ever. So especially those of you that stayed all the way in the end, thank you for that. And if you're willing to leave a Google review, that's super, super helpful. And thank you so much. We will send out the recording to everyone next week. It just takes time to convert the video over and put it up, but we'll make sure you all get the link. All right. Bye. Thank you so much.